of you to the World Antimicrobial Awareness Week Launch and Symposium 2024. My name is Collins Jaguga. I'll be your moderator this morning together with my colleague, Dr. Marianne Muimali. And I think before we start, it will be good for us to have a word of prayer. And so I will request us to stand up and request Dr. Muimali to come and open for us with a word of prayer. Kindly let us stand as we have the prayer.
Good morning. Let us bow down for a word of prayer. Mighty and ever-living God, we bless and honor your holy name this morning. We thank you for the gift of life, for the gift of this gathering, Jehovah Lord. We pray for your guidance, for your knowledge and wisdom, even throughout this Antimicrobial Resistance Week, the celebrations, Jehovah Lord. For those afflicted by the effect of antimicrobial resistance, we commit them into your able hands. We pray this believing and trusting in the holy name of Jesus. Amen. Thank you.
Amen. And you may have your seats. Just a few housekeeping matters before we begin our session this morning. And number one is to let you know that the restrooms are to your right if you need to go to the restrooms. And number two is if you have not registered, kindly ensure that you do register. I'm informed that there are those who participated in the media briefing event earlier on, and you did register there. Kindly note that you are required to register again. So please, if you haven't registered, please do so. And finally, those with posters, you are requested to ensure that your poster has been put up. Kindly see Dr. Gavin Orangi. Gavin, you could probably wave your hand so that we can all see you. So if you have a poster and your poster is not up, kindly see him and he'll assist you in putting your poster up. Otherwise, I want to take this opportunity to invite Dr. Irungu Kamau to come and give us some opening remarks. And as he comes, just to let us know why we celebrate the World Antimicrobial Awareness Week each and every year. So the World Antimicrobial Awareness Week is commemorated annually to raise global awareness of AMR and to encourage responsible use of antimicrobials in humans, animals, and the environment. It serves as a global call to action to preserve the effectiveness of antimicrobials and to combat the growing threat of AMR. Thank you, Dr. Irungu.
Yeah, thank you so much, Collins, and good morning, everyone. Good morning. It's not cold, so I believe we are well energized. Yeah, my name is Dr. Irungu Kamau. I work with the Ministry of Health, and in this context, I'm in the NASIC Secretariat, that is the National Antimicrobial Stewardship Interagency Committee. And on behalf of NASIC, I wish to welcome all of us to Movenpick as we commemorate this great week where we talk about antimicrobial resistance. So particularly on my behalf and on behalf of NASIC, it's a great honor as we gather to officially launch the World AMR Awareness Week 2024, and specifically for our country, Kenya. And we are cognizant of the theme, which is Educate, Advocate, and Act Now, which basically serves as a call to action for each of us to address a fairly significant public health challenge that we are facing. Kenya, of course, like many other countries in Africa, faces unique challenges in combating AMR. And like in our country with a population of 50 million people, our healthcare system sometimes is stretched to its limits. and we continue seeing misuse and overuse of antimicrobials in the human health, in the animal health. We are having a lot of effluent in our environment, but we know that we have a potential to lead the way in this fight. So the essence of this year's theme, as we have said, lies in 3 pillars. That is educate. So it's incumbent upon us to educate our healthcare workers, our farmers, our policymakers, and the general public with knowledge about the dangers posed by the misuse of antimicrobials and the key role played by infection prevention and control and farm biosecurity in mitigating AMR. We need to, the issue of advocacy. Advocacy requires a strong leadership collaboration, so we must ensure that AMR is prioritized at the national health policies, at the subnational health plans, and all the way to our implementation within our communities. So it is upon us to push for sustained funding, a robust antimicrobial stewardship programs, and also being able to avail affordable diagnostics to support evidence-based practices. So then we have to act now. So every day, of course, brings us closer to a situation whereby infections would be harder to treat if we continue misusing our antimicrobials. Therefore, we need to act now and take it upon all of us to mitigate this scourge. So this room, of course, demonstrates the kind of partnership we have, the kind of collaboration, which is a great insight in the dedication that all of us have in the fight against AMR. So thank you so much, and we wish all of us a very, very successful week. Asante sana.
Thank you so much, Dr. Kamau. We move to our next speaker on AMR and National Action Plan implementation, Dr. Romona Ndanyi. Karibu sana, daktari.
Good morning. Our chief guest, sir, Mr. Wasonga, representative of Ministry of Health, Dr. Kandie, all protocols observed. Ladies and gentlemen, good morning again. Where I come from, greetings are very abundant. Thank you. So I've been introduced. My name is Dr. Romona Ndanyi, and I'll quickly take you through this presentation on implementing the National Action Plan on AMR. And before I start, maybe just to ask you to bear with me. I have been through some AMR issues as well. Yeah, because of the cold, I had a sore throat, and I'm still trying to get used to my very hoarse voice today. I usually have a sweet voice. So bear with my hoarse voice for this week. So we're going to go through what we've been doing as NASIC in implementing our National Action Plan on AMR. And before I start the presentation, maybe just to inform all of us here that we've had our first iteration of the National Action Plan that was running from 2017 to 2022. It was a 5-year plan, a very ambitious plan indeed. Then by end of 2022, we reviewed the first National Action Plan and developed our second iteration that's running from 2023 to 2027. So currently we are on the second iteration. But my presentation on what we have been able to do will capture what we did in our first 5-year plan, as well as what we've been able to do as we started implementing our second National Action Plan. So just to start us off, as my colleague has already said before me, AMR, antimicrobial resistance, is one of the greatest global health challenges of our time. And it's becoming a leading cause of death globally. It's a growing threat in both animal health and human health, and affects our livelihoods and also affects food security worldwide. And currently, the World Health Organization has listed AMR among the top 10 threats for global health. Do we know about the other threats? Anybody? So AMR is among the top 10. What are the drivers of AMR? One of the drivers is overuse and misuse of antimicrobials, both in humans and in animals. We've seen a lot of misuse in terms of over-the-counter access to antimicrobials, getting antimicrobials without prescription, and sometimes not finishing a dose when certain antimicrobials have been prescribed, and that would lead to AMR. Other drivers include poor infection control practices, inadequate access to clean water and to clean sanitation, because when we have clean water, we have clean sanitation, then we reduce infections, both in humans and in animals, as well as other agricultural practices. Another driver is environmental contamination, because whatever it is we do in animal health, whatever it is we do in human health, somehow ends up in the environment. And when we contaminate our environment with, say, the resistant pathogens, or even the antimicrobial, then we accelerate the development of resistance in the microorganisms that are in the environment. Poor quality of drugs is also a driver. Yeah, and then suboptimal diagnostics. What do you mean by suboptimal diagnostics is if we are not able to properly diagnose the infections that are affecting either humans or animals, then we can't give the correct treatment. And this calls for use of proper use of laboratories to ensure that we get the correct diagnosis so that we can treat our animals using the correct dosage and the correct antimicrobials. This slide just shows you some of the impacts of antimicrobial resistance with regards to how it's affecting the Sustainable Development Goals. And from what we have described what AMR is, you can clearly see how it can lead to poverty. It can affect our universal health coverage. Because if there's an increase of infections, we are not able to treat our infections properly. We have increased number of days that people have to stay in hospital because the drugs that we have are not working. Then universal health coverage is affected and is not attained. With regards to economic growth, because animals are affected, our livelihoods are affected. And for us in Kenya, being an agricultural country, if our animals are not able to produce to the extent that they should, the proper extent, then that will affect our economic growth. If humans also are not getting well, are sick all the time, or we have so many people dying, we also lose the workforce in the country, and therefore that also affects economic growth. The other SDG that's affected is health equity and socioeconomy and gender. Let's just look at some of the impact, and I think Dr. Irungu mentioned some of them. What we have currently is that in 2019, it's been shown that the effect of AMR affected about 1,270,000 people. Yeah, this is it caused deaths of 1,270,000. 1,270,000. Get that right? And it is estimated that by 2050, this number of people dying due to AMR will increase to 10 million. So then it will become a #1 killer, and specifically in Africa, where we have issues with our health system, we have issues with our agricultural practices, the impact is going to be greatly felt. So today, we are seeing more than 700,000 deaths. I think this was data that was taken in around 2015 due to AMR. So postulated by 2030, it would get to about the cost of AMR would be around 3.4 million every year. You can try and figure out that. That's not in Kenya shillings, that is in USD. So you can imagine the impact. And as I said earlier, it is postulated that by 2050, if we do nothing about AMR, we will be seeing AMR causing deaths of about 10 million people each year. So we need to act now. We need to educate ourselves, advocate for AMR, and act now. And how are we addressing AMR in Kenya? We're using the One Health approach, and I think my previous speaker talked about that. We have to use a One Health approach and ensure each and every one of us is involved. Each organization that, each sector that has a role to play, plays a role in addressing AMR. So why are we using a One Health approach? Because this is an issue that affects multiple sectors. And we're talking about the Ministry of Health or the health sector. We are talking about the agriculture sector and the animal health sector. We are talking about the environmental sector, which is very important. And we are glad that now we are actually seeing a lot of effort globally as well as in the country to involve the environmental sector in addressing AMR. We also have other sectors that play a role. I know we have some of our counties that have involved, for example, the education sector, which is very important because if we start educating our young people early enough, then we will have champions early enough to address AMR. So how did we start addressing AMR? There was a call way back in 2015 by WHO, and they came together with the other, that time it was the three sisters, the tripartite. That was WHO, FAO, and OIE, who developed the Global Action Plan on Animal Antimicrobial Resistance. And after that, all countries globally were called upon to adopt the Global Action Plan and advocate and start working towards tackling AMR. So Kenya, we managed to develop our national policy and our first national action plan in 2017. You can see the photo there. Sorry, I don't have a pointer. And then after 5 years, we developed our national action plan, the second iteration that runs between 2023 and 2027. Just to point out is that when we developed the first national action plan, we only had the Ministry of Health and the Ministry of Agriculture through the Directorate of Veterinary Services that were involved. So that's the only One Health picture we had then. But as we moved along, we brought in the other sectors, so that as you can see, our second iteration of the National Action Plan has been signed by multi-sectors. We have the Ministry of Health, we have the Ministry of, the Cabinet Secretary, Ministry of Health, the Cabinet Secretary, Ministry of Agriculture and Livestock Development. Then we have the Cabinet Secretary, Ministry of Environment, Climate Change and Forestry. And the fourth one is the Cabinet Secretary, Ministry of Mining, Blue Economy, and Maritime Affairs. Yeah. Blue Economy is where we get fish, and fish being part of our food system and where we can also get AMR is important. So currently, the four ministries are working together hand in hand to tackle AMR using a One Health approach and implementing the National Action Plan together. So I'll just take you through a snapshot of what we have in our National Action Plan to share the strategic priorities that we have captured or outlined in this snap. So we have 6 objectives. This is different from the Global Action Plan, if, for those of you who are aware of the GAP. The GAP has 5 objectives, but for us in Kenya we have 6. Because from the lessons learned during the implementation of the first National Action Plan, we realized that we needed to build capacity in governance. So we had to pick that out and put it specifically in our National Action Plan so that we come up with activities of how we are going to strengthen our governance and coordination in addressing AMR. So the first objective is to establish and strengthen governance coordination mechanism at the national and county levels. The second one is public awareness and education. And this is one of the activities that we usually carry out every year as one of the activities under this objective. And our main focus is to improve awareness and understanding of AMR through effective communication, through education, and through training. And I believe we are doing that very well today. Our third objective is surveillance and monitoring, focusing on strengthening the knowledge and evidence base on AMR through surveillance and research, because we need homegrown evidence. We need to know what exactly is happening in Kenya for us to know exactly how then we can address AMR. So we're doing that through surveillance. The fourth one is IPC, infection, prevention and control, and hygiene. In this objective, our aim is to reduce the incidence of infection through effective sanitation, through hygiene, and through IPC. For those of us who are from the animal health sector and the agriculture sector, basically you're talking about proper farm biosecurity measures and good husbandry, both for animals and for plants. The fifth one is appropriate use of antimicrobials. Our focus is to optimize the use of antimicrobials in human, animals, and plant health. And the last one is research and development. This is to support sustainable investment and increase investment in new medicines, diagnostic tools, vaccines, and other alternatives. And I'm glad I can see we have representation from the research institutions here. And we'll have a number of presentations that will be presented today and tomorrow that will showcase what we've been doing, what kind of research we've been doing towards addressing AMR. I've talked about multisectoral governance. That's our first objective. And for us in Kenya, we do have a structure which we use, our governance structure that we use for addressing AMR. And this structure has a level at the national level. We have a national level and the county level, because most of these activities, most of these sectoral aspects are devolved. So at the national level, we have the National Antimicrobial Stewardship Interagency Committee that consists of the 4 ministries I've mentioned earlier. And it consists of the steering committee that's led by our PSS from our CSS and PSS from the 4 ministries. We have a technical committee that's led by the directors in these ministries. And then we have the AMR Secretariat. In other words, the Kanda ya Moko, the ones who steer the wheel at that low level. So how do we coordinate our work with the CASIC? We do this through the intergovernmental relations. Then we have recommended that at the county level, we do have the County Antimicrobial Stewardship Interagency Committees. And these, currently we have established 20 of them. in Nyeri, in Murang'a, Mugoma, Kisumu, Kilifi, Mombasa, Kakamega, Makueni, Trans Nzoia, Machakos, Kiambu, Uasin Gishu, Embu, Bomet, Nairobi, Kisii, Nandi, Busia. The new kids on the block are Laikipia and Kitui. Please clap for these K6 because without having people at the ground, then on the ground at the mashinani, then it would not be possible for us at the national level to make any impact. So our second objective on awareness, I'll just go through some of the milestones we've been able to make, or some of the achievements. In enhancing public awareness, we've been holding AMR awareness campaigns every year since 2015. We have an AMR communication strategy, and this has been reviewed thanks to Red Cross, I think, and Rocket. We develop a number of IEC materials and bulletins which we share with our counties so that we can spread the message across. Then we usually have advocacy meeting. We've had one this year with the Parliamentary Health Committee to advocate on adoption of AMR and funding for AMR. Then a number of conferences we usually hold across the year. For example, last year we had the IPNET Kenya conference, and then we had AMR Scientific Symposium. And then we have a number of other conferences that are held, and some of these conferences, like the KVA National Conference, usually has topics or themes that cover AMR. Another way we've been carrying out awareness is promoting education and training in AMR and IPC by sensitizing professionals on AMR, IPC, antimicrobial stewardship, biosafety, and biosecurity. Then we also have been carrying mentorship both physically and virtually. And another activity we've been doing over time is working hard to build capacity of our media personnel on AMR. Like earlier today, that's what we were doing between 7 and 9, sensitizing our media so that we are able to get the message out through our media houses. Still under awareness, promoting education and AMR and training on AMR, AMR is covered in some of our pre-service training and also most of our in-service training. And of course, we also have continuous professional development in human health and also in animal health that cover AMR. We also have been conducting training using standardized modules. We have one module for AMR surveillance, for example, that has been posted on the Ministry of Health website and is available for anyone who's interested in learning more about AMR to access. A mentorship also is carried out both on-site using a platform, for example, the ECOF platform, which integrates AMR, antimicrobial stewardship, IPC, and others. On to surveillance, what have we been able to achieve? We first and foremost started by establishing our AMR national reference centers. And for human health, our reference center is the National Microbiology Reference Lab. And for animal health, we have the National Veterinary Reference Lab in Kabete. Those are our reference center for AMR surveillance. In addition, we have sentinel sites that we have established. So we, as a country, we agree that our sentinel sites will be, for animal health, will be the veterinary labs, and for human health will be the healthcare facilities or hospitals. So currently we have a total of 24 sentinel sites, and we are still working on increasing the sentinel sites because this is where we would get the data that then can show us what kind of AMR trends we have in the country. What we do is that currently we are able to report our surveillance data annually So for human health, we report to WHO GLAS, and for animal health, we have now we have now started the process of reporting to a new platform called Infam, so that we share our data globally, and anybody who's interested can actually see what is happening in Kenya. And we also can use to come up with policies with regards to AMR. Still on surveillance, we've also been able to work on quality assurance of our data and of our procedures in the laboratory. We have been able to standardize our laboratory procedures across human health and animal health. We have enrolled all our surveillance sites, and all of them are able to carry out external quality assurance programs, so that whatever results that these labs give, we are assured that these are good quality data, and they can stand they can actually be used for decision making. We also have isolate referral and retesting, so that we are able to gauge what our sites are doing, and where we have issues, then we can address that. So in implementation of our laboratory quality management system, which is very important for surveillance, I'd like to maybe mention that the National Microbiology Reference Lab at the National Public Health Lab is accredited for bacteriology tests under the ISO 15189 version 2012 by KENAS. KENAS is the Kenya National Accreditation Services that we use for accreditation. The NMRL is also accredited as a national external quality assessment provider under ISO 17043. The lab in Kabete has accreditation for bacteriology test and AST, that is the antimicrobial susceptibility testing, to ISO 17025, the 2017 version, also by KENAS. And we have 8 of the 18 labs in human health that are in the surveillance network that have been accredited to 15189. So this is to show you that whatever data that we share with our partners, the data that we share with our policymakers, is good quality data. This is just to show you what we are able to produce from our surveillance sites. We use the laboratory information management system, and we have different systems for human health and animal health. And we also were able to develop a One Health AMR surveillance system, which then compiles or collates all the data from human health and animal health into one dashboard, and then this can be visualized by the personnel who have rights to visualize this data. It's our hope that we can actually extend the rights to our policymakers, so that they'll also be able to, at a click of a button, be able to see the kind of data that's coming out from our surveillance sites. And you can see the kind of maps that this system is generating. Very informative maps. You can see the one on top, just showing us where, for example, E. coli resistant to gentamicin is found in the country. And the one below, that is in humans, the one below you can just visualize E. coli resistance, for example, to tetracycline in animals. The areas in red, that's where we have some resistant E. coli. A very good system. Yeah. See, just still on surveillance, my apologies, because I have a bias to surveillance. I may talk so much about surveillance. So if there are issues with time, please, moderator, please let me know. Yeah, so over time, we've been able to increase the number of samples that we're seeing from our health facilities, as well as the ones that we're seeing coming in from animal health. So all the way from 2018, we only used to get about 64 samples only for surveillance of AMR. And today, we are talking about over 26,000 samples. In animal health, comparing 2022 and 2023, In 2022, we only saw about 7,000 samples, and now we can see we are increasing the number of samples. And the more samples we get, then the more data we can get to enable us make better decisions on trends and how to address AMR. This just goes to show the kind of specimens that are tested in the laboratory for purposes of AMR surveillance. In humans, mostly we get blood samples. About 32% of most of the samples are blood samples. This is followed by urine samples. We also have others, various swabs. We have stool samples, urogenital, central CSF samples, among others. On the other side, in animals, we are seeing a lot of bovine milk as the samples, specifically for passive surveillance, and avian cloacal swabs. And the reason why we have a lot of avian cloacal swabs is because we had a big project that was looking at surveillance in poultry. But most of the times, most of our samples, the samples that are handled in animal health are bovine milk samples. We've also agreed on the priority pathogens, both in humans and animals. And you can see that E. coli features, we can see Salmonella, Staphylococcus aureus, Klebsiella pneumoniae, Pseudomonas aeruginosa, yeah? And these are featuring both in human health and animal health, showing the importance of why we need to address this using a One Health approach. What kind of data are we seeing surveillance when you're carrying out surveillance for AMR? Just a snapshot. For example, when you look at the E. coli that we've been able to isolate, most of them are susceptible to meropenem, to amikacin, and to nitrofurantoin. However, we're seeing high resistance to fluoroquinolones, ciprofloxacin, and just to take note that we use a lot of ciprofloxacin also in animals, and we use a lot of cotrimoxazole in animals, and you're seeing resistance in human samples. Just to show you also what's happening in the animal arena, E. coli, just using E. coli, susceptible to meropenem, to ceftriaxone, and to gentamicin, but then high resistance seen in ampicillin, in cotrimoxazole, and in tetracycline. We also have, under our fourth objective, infection prevention and control, biosafety and biosecurity activities. So in interest of time, maybe I'll just skip this because I'm sure we'll have a presentation on IPC at a later stage. Yes, I think somebody talked about the importance of hand washing. And we've tried to look at data that shows how the impact of hand washing, to getting infections. And all of us can take note of what happened during COVID, when we had stricter, or rather we were forced to comply with hand hygiene. There was a reduction in infections, and actually I think some hospitals were crying, some pharmacies were crying, they were losing business because nobody was falling sick. I think we should go back to that era. Under promoting prudent use of antimicrobials, we have developed guidance. For example, we have the National Antimicrobial Stewardship Guidance for healthcare settings. We also have the guidelines for prudent use of antimicrobials in animals. Other documents that we've produced or developed that are supposed to assist us to promote prudent use are as shown. We have the essential medicines list, then the national medicines formulary, the essential diagnostic list, the essential medical supplies list, and specifications for Kenya essential diagnostic list. There's a reason why I said veterinary, because that's one of the things we are doing next week. We are coming up with an essential veterinary medicines list as well. Other than that, we also have antimicrobial use and antimicrobial consumption monitoring. In a nutshell, I'll just talk about AMC as the aggregated data, such as import data, wholesale data of all the antimicrobials that come into the country. And AMU would be tracking exactly where these antimicrobials are used. And we do have two regulators, that is the Pharmacy and Poisons Board and the Veterinary Medicines Directorate, that monitors AMC at the national level. This just shows you the kind of data we are getting from antimicrobial use, or on antimicrobial use and consumption. And you can see in animal health, we have a lot of tetracycline that comes in for purposes of animal health. We also have aminoglycosides, penicillins, and macrolides. Then the other graph just shows us the comparison between antimicrobial use and use of microbiology lab for diagnostics. And you can see we are not doing very well. For the 8 hospitals that were monitored, it's only one that actually uses a lot of microbiology lab to give direction on which drugs to use. So that's an area that we need to improve. Under research and development, we have a number of research projects. Quickly through them, just the Rocket project is a One Health project spanning Kenya, Uganda, Ethiopia, and Tanzania. And that project promotes local research. Local research and collaboration across sectors to strengthen decision-making in AMR. We also have various researches that have been carried out, some sponsored by or supported by USAID, MTAPs, by KEMRI. Let me not, in the interest of time, I'll just go through. We have one that's supported by Danida, looking at quali-food, improving milk and chicken meat products. We have climate-smart agriculture technologies that also look at improving the husbandry of agricultural practices, and others like MadTech, looking at how we can also use ICT to control AMR in Africa. I think this is my last slide in interest of time. Thank you very much.
Thank you, Dr. Ramona. Very passionate about surveillance. We had a media briefing in the morning, and there are lost and found items. So in the event that you forgot, there are car keys and a notebook in the media briefing room. Kindly pick them from our desk. So next we do have, in the house, we have sponsors, our partners who are here with us. And maybe going back to Dr. Ramona on the National Action Plan, from a personal perspective, in your own sphere as an individual, what are you doing to prevent antimicrobial resistance? I do not want an answer from you, but just consider that, and if there is anything you need to do, please do it to create awareness so that we can stop this plague of AMR. So we are so grateful and honored to have our partners in the house. And in the interest of time again, I would want them to come forward and make some remarks. I want to call upon Fleming Fund. Just take maybe about 3-4 minutes so that you can make your remarks. We do have Fleming Fund, we do have USAID, we have CDC, Kenya Red Cross, Biomerio, we have the quadripartite. If we do have representative from those organizations, kindly step forward so that you can make your remarks. Thank you. And as they come forward, let's clap for them. Thank you so much, Bwana Boleva. Karibu sana. Uh-huh. You can use this one? Or you want to move around?
No, this is fine. Good morning, good people. It's always good to be fast, isn't it? Then you hog the space and take over everything. Our guests, invited guests, ladies and gentlemen, my name is Boleva. I stand here as a representative of the Fleming Fund that is involved, has been involved from the beginning of the National Action Plan in Kenya. And we are proud to be associated with the government of Kenya. We work alongside them to enable them and help them execute the mandate of AMR. We work as a consortium in Fleming Fund. We currently are a consortium of two. ILRI, which generally handles the entire project, and ILRI, the arm that handles the animal health sector. We partnered with the University of Nairobi, which handles the human health sector when it comes to AMR. In the NAP, we are leaning more towards the surveillance section of the NAP. In the initial phase one of the project, just to take you back a little bit, we did a lot of work around renovating and equipping of some of the Sentinel sites. We are working in just slightly under 20 surveillance sites. We did a bit of renovation of some of these sites, put in equipment, bought lab reagents, did a lot of capacity building on the lab people, and this is an ongoing process even as we speak. Reagents and consumables, including PPEs for the lab staff, and capacity building of the lab staff and other interested parties. But when it came to the second NAP, I might be mixing people up. The National Action Plan is the NAP, not that we went to sleep. It is a National Action Plan. The second National Action Plan, we are actually focusing on data and retrieval of data and generation of this data, and to see how can this data then be used to create policy. As you saw some of the data that has been presented out there, there was only one hospital that was actually using the data they have to create a clinical interface with the lab. And that is an important state for us, because without that data, we would not know that it's only one. Now we know. Now we are able to encourage the other sites, especially to start using the data that is being generated. From Fleming Fund, we initially worked a lot with the human health and the animal health, but I'm proud to say that in phase 2, we have strongly and deliberately moved to include the environmental sector in this space. We know that there are many sectors that would be involved. It's a cross-cutting One Health initiative, but the Chinese say that the journey of 1,000 miles begins with one step. So we began with the animal and human health sector, and in phase 2 we are vigorously engaging with the environment sector. And also we have deliberately in phase 2 started to include a little bit of the private sector in human health, because that's an area that has been neglected for quite a bit of a while, and we are able to get a lot of data to inform us what is happening in the market. Fleming Fund also, Fleming Fund is structured in such that we have the country grant that is run by ILRI. Professor Eric was here a few minutes ago. Unfortunately, he had to run off. The seat was biting him because he was in a meeting and he kept on postponing. And I can see I'm being warned. Can I borrow another 1 minute, Daktari? Yes. We have regional grants. We have the country grant, which oversees the country implementation, And then we have the regional grants that you have heard being mentioned here, some including FIND, who have done quite a bit of work on technical assistance, and also digitization and optimizing the network, because the CDW, the Central Data Warehouse that you see here, was implemented by the Fleming Fund. And FIND is actually doing a lot of work in that space. Some people like Radar, ASLM, EXA, AMRO, giving all sorts of technical assistance through the Fleming Fund as regional grants. And then we have some of them who are also strategic alignment grants. I can see they are looking at me badly, but it's okay. I have the microphone, so I might as well steal another 1 minute. Just to quickly, in moving forward, the issue is sustainability. How do we sustain these gains that we have had for the last 7 years? In our mind, our key ask, our key plea to government is to try and include these gains into the government structures. The revenues, the equipment that has been put in these labs is costs a tidy sum, and it would be a shame to leave them to stay there as white elephants. It would be great to see that these equipment and infrastructure and training is included in government budgets, both county and national government, so that we have some form of sustainability of these efforts. I think I want to stop there, because if you leave me here, I'll start talking politics, and that is not good. So I want to thank you so much. Thank you for the opportunity on behalf of Fleming Fund, the Director General of ILRI, and the entire Fleming Fund fraternity. Thank you so much for the collaboration that you have given us. These doors we knock and we are let in, we don't take it for granted, and we look forward to supporting the government more and more to achieve what they need to achieve in the AMR space. Thank you so much.
Thank you. Thank you, Dr. Bolivar. I can tell you are a bully from primary school. So I want to call upon Dr. Lois Ombajo from the University of Nairobi. Just a minute. So that she can finish the other wing of the collaboration between ILRI and the university. Thank you.
Thank you so much. Good morning, Yes, good morning, everyone.
Good morning.
So you say good morning. Good morning, everyone. All right, I think mine is really thank you all for coming. I think everybody in this room is here because of the passion they have for mitigating AMR. Also to thank the Ministry of Health, because they've given us incredible support as we've worked, particularly supporting the human health activities in Fleming Fund. I think UON has been privileged to support a number of activities, working with the counties, working with several facilities to work on antimicrobial stewardship, supporting issues of data review, and importantly, supporting use of data in developing antibiograms. And as we'll see today, we now have for the first time the national guideline on antibiotic use in human health. So we're incredibly proud and really privileged to have worked with very many people in this room and very many people working in the counties. And I just want to echo something that Bolivar said around sustainability. And this goes to the Ministry of Health. It's not every day that you get the opportunity to address the Ministry of Health, Dr. Kandia and your team. If we go to many of the labs that we're working in, practically everything that's being used in the microbiology lab is currently being supported by a partner. And the question is, once some of this funding ends in a year or months, what happens next? Will we have no data? So the Ministry of Health really has to work at ensuring that government supports some of this work. As Kenyans, we cannot continue to rely on partners for forever. We have to think about how does government support the work that needs to be done in order to control AMR. So that is a task that we send you back with, that next budget will hear flour, transport, AMR will be right on that list in the budget, that we must think about how we fund the work that we do. And I think for everyone is that AMR is never an individual activity. It's about people working together, people collaborating, whether it's in infection prevention and control, whether it's in surveillance, whether it's in developing guidelines, and in antimicrobial stewardship. We all have to continue working together. So let's advocate and let us act now. Thank you so much for the opportunity.
Thank you so much, Dr. Lois Ombajo. Could we have the next speaker, kindly? There was a gentleman. Take the stage, please. Karibu.
Okay, thank you. Thank you very much. My name is Dr. Paul Olale from Kenya Red Cross. And I will start by saying that this is a privilege to be part and parcel of this commemoration of the World Antimicrobial Awareness Week, that is 2024. Yeah, as Kenya Red Cross, we are working on a project on antimicrobial resistance with One Health approach that is actually under the Rocket Consortium, which we are in with ILRI, KEMRI, that is in Kenya, and then we also have the Ethiopian Institute of Public Health, that is in Ethiopia, and then we have Muhimbili in Tanzania, and we also have Makerere University in Uganda. So I'll just take a minute or two to give us a brief of what we're doing in the country. And ours as a consortium is basically communicating to the second and sixth strategic objective of the NAP, that is public awareness and education. And we have the research and development. The research and development wing is actually taken care of by KEMRI, which is actually much more into evidence-based diagnosis, trying to capacity build our key referral laboratories, something that has actually begun. It was launched last month. On the Kenya Red Cross wing, we've been basically on community awareness and community sensitization, majorly in 2 counties so far, that is in Kajiado and Uasin Gishu, where we've been able to capacity build community health promoters and sub-county teams, the chairs and some of the PHOs at that particular level, basically to be able to do a household level kind of sensitization against communication around risks and consequences of inappropriate use of antimicrobials. So this is something that has really been happening since June this year, and it has taken shape. And we appreciate the kind of feedback that we are getting from these particular sets of communities. Hoping that now we are really going to intensify this with the Waaw. There is active rollout that is actually going on from today throughout this particular week, where we're really going to get into the households just but to spearhead what has been going on. So with those many remarks, I think because of time, I would want to stop there. But again, I won't be justice to stop actually calling upon the ministry. You know, again, I'll echo what Dr. Mbajo said. Getting an opportunity to speak to the ministry is always not an easy opportunity. Yeah, I think, again, we just need to at least have, as a ministry, an allocation to this particular bit, because AMR is really a problem, it's a real challenge, and from the data that we're seeing here, there have been little consideration as far as One Health is concerned, and I'm happy that we have the NASIC. If we can easily be able to have these cascaded down so that the CASICs in all counties, we have very few. We have all the CASICs capacity built or strengthened. I want to believe that we are gonna be able to revert to whatever projections that are here by 2050. Otherwise, thank you very much, and let's have a good week. Thank you.
Thank you, Mr. Olale. A hand clap, please. Let's have our next partner. Karibu sana. Aha.
Good morning. I don't know if you are like me, but the figures that were given, the 1.27 million, were mind-boggling for me, and I hope the same was for you in terms of taking action with regards to AMR moving forward. My name is Joshua Kimutai. I'm privileged to stand in front of you on behalf of FAO, and I'll be giving the remarks on behalf of our FAO representative, Ms. Nyabenyi Tipo. Our chief guest, Mr. Jude Wesonga, representative of the PS State Department of Livestock and Development, Ministry of Health, Dr. Charles Kandie, Director Health Standards, Regulation and Quality Assurance, representative from the DVS, Dr. Evans Muthuma, representative from CEO KVB, Dr. Benson Kibore, a representative from Calro, Dr. Monica Maichomo, and last but not least, from KEMRI, Dr. Robert Onsare, as well as acknowledging the partners from the quadripartite who are here, WHO, UNEP, World Organization for Animal Health. I'd also like to recognize representatives from the funding agencies and implementing partners, namely from USAID, Ricardo Echela, the research institutions, universities, all protocols observed, ladies and gentlemen. On behalf of FAO, it is a privilege to join you for this World AMR Awareness Week, an urgent call to action highlighting the growing global crisis of AMR. FAO believes that we must respond with coordinated and sustained efforts to combat AMR and protect public health across all sectors and along with the agri-food systems. Your Excellencies, dear guests, ladies and gentlemen, this year's theme, Educate, Advocate, Action Now, underscores the need for raising awareness, advocating for strong commitments, and taking immediate action across all sectors to tackle AMR. During the recent 79th UNGA, United Nations General Assembly, high-level meeting on AMR, Kenya joined global leaders in pledging to ambitious targets, which includes a 10% reduction in AMR-related deaths by 2030. The UNGA 79 declaration emphasizes the need for sustainable national financing and robust funding mechanisms to support global AMR initiatives, which highlights Kenya's commitment to this critical fight in alignment with global initiatives. As a result, FAO acknowledges the Kenyan government commitments to these crucial initiatives and supporting the declaration's appeal for multi-sectoral approaches to AMR under the auspices of One Health frameworks. Kenya is also proactively promoting the FAO initiative known as RhinoFarm, which is the reduce the need for antimicrobials on farms for sustainable agri-food systems and transformation. This was mentioned by Dr. Ramona, which was launched in April 2024. And also INFARM, which is the International FAO Antimicrobial Resistance Monitoring, which was launched in early 2022. This represents FAO's global efforts to minimize the reliance on antimicrobials in agriculture as a means of combating the growing challenge resulting from AMR. RhinoFarm is designed to transform the agricultural practices significantly on reducing AMR use on farms through enhanced biosecurity, infection prevention, and improved animal health management. With the rise of AMR, there is increasing pressure on agricultural systems to minimize the use of antimicrobials, which can lead to drug-resistant infections affecting both animal and human health. And this is where RhinoFarm comes in. It aims to preserve the effectiveness of these essential drugs and promote sustainable food systems by emphasizing preventive health measures and responsible antimicrobial stewardship aligned with the ongoing multidisciplinary and multisectoral engagements. On the other hand, INFAM complements this effort by providing a global platform for countries to monitor and share data on AMR across animal and food systems, enabling targeted interventions and improving transparency. Together, RhinoFarm and INFAM serve as key components of FAO support for Kenya and other nations in the global fight against AMR. Looking at some of the key milestones and achievements in Kenya's AMR journey over the key years, FAO is very proud to have been part of establishing the county AMR units. Kenya's 18 CASICs, as has been highlighted by Dr. Ramona, have become vital hubs for local AMR initiatives, and FAO is committed to expanding these units to ensure AMR control measures with every corner of the country. Advancing lab and surveillance capacity, FAO has been able to move on this initiative through supporting assessment of the AMR surveillance system, and we noted during the assessment carried out this year that the progressive improvement pathway stage for AMR in Kenya moved from progressive improvement pathway stage 1 to stage 3 in AMR surveillance, which has reflected improved lab capacity and data systems. As previous speakers have spoken, we have focused a lot on building the lab capacity, which is critical in generating the quality data that will be able to improve our AMR surveillance. Also, with regard to national action plans, Kenya is implementing the 2023 to 2027 NAP on AMR, which FAO was also a part of, in alignment with the UNGA 79 targets. And this plan includes robust monitoring mechanisms and a roadmap for AMR control. Moving forward, the main strategic focus for FAO will be scaling up surveillance and data reporting. FAO will continue to work with Kenya to meet UNGA 79's targets for quality AMR data reporting, ensuring contributions to global AMR surveillance databases. Secondly, we'll also focus on strengthening policy implementation and stakeholder engagement. By aligning Kenya's policies with global goals, FAO will support Kenya in mobilizing resources and implementing effective integrated AMR strategies in the context of One Health. We'll also continue to promote responsible antimicrobial use in agriculture through RhinoFarm, and FAO and Kenya will prioritize reducing AMR use on farms through biosecurity, livestock vaccination, and sustainable animal health practices. We'll also put a lot of effort on enhancing One Health collaboration, recognizing that AMR impacts every sector. FAO will as well continue to foster cross-sector partnerships to build a united One Health approach to AMR containment. Lastly, my message on behalf of the FAO representative is to let us unite in our commitment to combat AMR by educating our communities and advocating for strong policies that prioritize public health. Together, through immediate and coordinated action, we can protect lives and ensure a sustainable future for all. Thank you for your attention, and I wish us all a successful Waaw 2024.
Thank you, Joshua from FAO. Could we have our next sponsor, please? A hand clap for Joshua.
Good morning, everyone. My name is Ricardo Echelar. I am the Regional Emerging Threats Advisor for USAID Kenya and East Africa. Highly grateful for being here today. So thank you to everyone. Recognizing our chief guest, Judy Wasonga, representative of the PS Livestock and Development, Dr. Kandi from the Ministry of Health, Dr. Kibere from the representative CEO of KVB, Dr. Matuma from the representative of the DVS, Dr. Aboge, representative of University of Nairobi, Dr. Machoma, the representative from VSRI Calro, all of our partners, and all other distinguished guests, all protocols observed. On behalf of the USAID Kenya and East Africa Mission leadership, I'd like to extend our appreciation as well to the Kenyan government and to the organizers of today's launch, including Dr. Collins, Dr. Ngumu, Dr. Kamau, Dr. Ramona, and Dr. Tunoi. And I'd also like to recognize all of the stakeholders and partners here today, including, as we've heard, from Fleming Fund, from the Red Cross, our colleagues from the U.S. Centers for Disease Control and bioMérieux, and many of you who are here who recognize AMR as an important issue that we have to address. So as we all know, the World Antimicrobial Resistance Awareness Week is an annual reminder and a call to action. And AMR is one of the priority global health security technical areas for the U.S. government, and is a strong example of the partnership that the U.S. has had with Kenya over the last 6 decades. Now, we are here today because we recognize antimicrobial resistance, also known as AMR, as one of the greatest public health threats the world is facing. We've heard this repeatedly this morning. And also we heard that this was highlighted during the second high-level AMR meeting during the UN General Assembly that took place a couple months ago. And during this meeting, we also heard that by 2050, there will be nearly 10 million preventable deaths due to AMR, and an economic impact globally of nearly $100 trillion US. And in Kenya, AMR could have dire consequences in the push for increased primary health care. As a result, people have termed the threat of AMR as a slow and silent tsunami. Proper antimicrobial stewardship is one of the most important public health actions that we can take today, and by coming together to work through a One Health multi-sectoral approach, we are working to prevent this tsunami from becoming a reality, thereby protecting the ones we love and protecting future generations. But to fully address the threat of AMR, as we've heard, we must work to bring multiple sectors together at the national level, county level, and in communities. This includes bringing human health, animal health, and the environment together for coordinated action, and we must not forget the private sector. This includes active surveillance to monitor the risk, working with consumer groups to increase awareness and education so that individuals understand the proper use of antimicrobials, strengthened infection prevention and control measures, including increased access and availability to safe water for improved sanitation and hygiene and proper waste management, research and development for new prevention tools, including vaccines, and working closely with the animal health sector, recognizing the role of improper antimicrobial use within agricultural production. The good news is that all of this is already outlined in the National Action Plan on Prevention and Containment of AMR 2023 to 2027. And Kenya is leading this charge through its National Antimicrobial Stewardship Interagency Committee, and at the county level through the CASIX as well. And Kenya serves as an important example to other countries in East Africa and around the world. And as part of this leadership, I also want to commend the Ministry of Health and all partners in the launch and for hosting the new online patient health workers safety documents portal and mobile application. So to conclude, to address AMR, it will be a marathon and not a sprint. Something that I know that Kenyans do well and exceed and lead at. So I have great faith in the work that you all are doing, not just today, but those who will be presenting your research and of the future. So thank you to all. Asanteni sana.
Thank you, Mr. Ricardo. Could we have CDC? Are we in the house? Thank you.
Good morning. Yeah, thank you. Our chief guest, Mr. Jude Wesonga, Dr. Kadie, representing the Ministry of Health, Dr. Benson from the CU, KCB, Dr. Evans, DVBS representative, Dr. Gabriel, representing the Dean, University of Nairobi, Dr. Monica from Carlo, and all partners and all protocol observed. My name is Dr. Linus Degwa, representing our country director from US CDC, and want to say thank you to the organizers for inviting us and for this great occasion, which I'm proud of and to be part of from the first Waaw week that this country started celebrating in 2017. As CDC, we are honored to partner with the Ministry of Health and work as part with USAID as USG to support the work of AMR, IPC in this country. One of the important aspects to mention is that in terms of seeing this work grow, CDC in 2015 started with 2 AMR surveillance sites, which, as you have seen from Dr. Ramona, have increased to 20 sites. And we continue working with our implementing partners to ensure that robust data, laboratories and the technicians are able to produce quality data. That is very important. In terms of enabling to achieve the NAP, which Dr. Ramona alluded to quite well, CDC has worked very well with the Ministry of Health, and especially in coordination and supporting the establishment of the county Antimicrobial Stewardship Interagency Committees, the CASICs, and in collaboration establishing the CIPCAC, the County IPC Coordinating Committees. Because as you've seen that without IPC, we are not going anywhere with AMR. In terms of awareness, as CDC in 2017, we established and supported the Ministry of Health in establishing the ECO platform, which we are proud of to see that most of us, and that has grown to integrate One Health concept, which is learning every 2 weeks. And that is really kudos to the Ministry of Health. Since we handed over that platform, they have continuously supported that. And in terms of supporting the AMR surveillance and monitoring, from our 2 sites, we have expanded and we continue working together with our implementing partners to ensure that that surveillance, the data is actually quite robust. As I end, I want to say that AMR is our silent enemy, as we have learned from the data. And not only an enemy, it's a real terrorist. It does not segregate whether you are high or low, rich or poor. It doesn't segregate whether you are an animal or a human being or in the environment. This we must all come together to fight because it's a real terrorist, and we must all get engaged in fighting the AMR, which is antimicrobial resistant. And as we think about it, it's not only the AMR in the bacteria sector that is antibiotic, we're also talking about the AMR in the fungi, in the virus, and also in the parasites. So I would like to really acknowledge our implementing partners. The University of Nairobi are here, represented by Dr. Lois, ICAP represented by Doris, WSU and FHI 360, and APHL and AMREF. With that, I want to say thank you for inviting us.
Thank you from CDC. A better clap, please. Thank you. So could we have our next speaker? Biomerio, are you in the house? Thank you.
Thank you. So the chief guest, Mr. Jude Wesonga, senior leadership from the One Health Ministries present here this morning, the distinguished guests from various state and non-state actors involved in the AMR, AMS space. Ladies and gentlemen, all protocols observed, good morning. So my name is Dr. Kiplangat Sigei. I'm representing Biomerio. For those who may not have heard of this elegantly named diagnostic company, Biomerio is a French company that has been involved in diagnostics for over 60 years, and we pride ourselves in being a key diagnostic partner of choice for various agencies represented here and across the country. So our role in diagnostics has been to ensure that the labs function well, and we are happy that we have a good relationship with most as we continue to build other relationships as well. So in terms of what we've done in supporting the National Action Plan, our main focus areas have been the two main objectives relevant to us, which is supporting the appropriate use of antimicrobials through ideal diagnostics as well as well-equipped healthcare workers, and then strengthening research and surveillance through various projects. And we continue to work with a lot of you in the room and others who are not here, and we want to continue doing this going forward. So I think for us, we're happy to be here. We're happy to support the Waaw Week, and we are always open for further discussions and further engagements on how we can expand diagnostics, not just for AMR, but across various fields. And I want to echo one of the speakers who talked about sustainability. We are here as a manufacturer, and we are willing to discuss. Sometimes we know we feel there are barriers towards accessing some of the diagnostics, but we're very open, and some of the facilities, not just here, but elsewhere, can attest to that. So I think our parting shot as Biomerio is, without diagnostics, healthcare is blind. Thank you very much.
Thank you, Biomerio. I hope I got that right. So do we have our next partner, the World Organization for Animal Health, a representative from Waaw? If not, WHO, World Health Organization. Thank you, Daktari. Karibu sana.
So my name is Mark. I work for the World Health Organization, Emergency Preparedness Response Program, but one of the areas which we tackle also is One Health, which encompasses AMR. I didn't know I was supposed to speak, but I'm here on behalf of our country team lead, Dr. Abdulrahman Diallo, who is engaged in another activity. And as WHO, I think Joshua from our sister organization in the UN FAO, he has had an in-depth speech. And I will qualify that as behalf of the quadrupetite. But just to be clear is that the quadrupetite is a joint secretariat that brings together the 4 UN agencies. And until 2 years ago, I think UNEP came on board to strengthen the environmental aspects. The quadrupetite is hosted by WHO, and it's a multi-sector engagement in AMR. And just maybe to mention a few things that probably WHO has been taking lead, both at the global level, but also the commendable job that was detailed here by Dr. Ramona from the DVS. So the Global Leaders Group on AMR, I think, is a unique platform that actually has involved partners, to come together in terms of capacity building. And one of the areas that WHO actually strengthens is capacity building. When you go online, you'll find modules on AMR, and these have been adopted actually locally. I think last week we were in a public health emergency meeting where we were reviewing some curriculums to train local responders. And the way actually is to have the digital learning platforms hosted by the ministry that also are supported by WHO and others to integrate AMR as part of the One Health curriculum. Having said that, most of you are aware of the Access, Watch, and Reserve. This is a classification of antibiotics that has been developed by WHO under the stewardship program. So it's very important for clinicians actually to understand the dosages, route of administration, and actually the choice of antibiotics, whether they're the first-line antibiotics or second-line antibiotics. And so this is being championed by the AWARE platform by WHO. But all of us refer to GLASS. GLASS is not actually the glass that breaks, but this is a surveillance system on the use of antibiotics that has been championed for a very long time by WHO. Very keen to see what FAO is doing actually with the infam, and I think that actually now complements the whole picture of AMR surveillance, building upon many years of the revised strategy of GLASS that was revised actually a few years ago. When we look at the priority pathogens, this year, WHO has revised the list of priority pathogens. And actually, most of them, as most of you will understand, Klebsiella is one organism that has been actually, troublesome in terms of the IPC. And these priority areas will form the agenda for the next few years that will be focused on in terms of actually strengthening the quadrupetide. But just to echo the words of the WHO Director General, Dr. Tedros, last week in the high-level ministerial panel discussions, I think there are 4 key takeaways where WHO is focusing. We must be cognizant that finances is a challenge, and therefore the issue of sustainable financing from both domestic and international must be sustained. We are aware of over-reliance on foreign funding, and I think this has affected the agenda that is set forward in terms of what are the priorities of countries. But more importantly, the issue of increasing equitable access to quality antimicrobial use, and this actually just to ensure that drugs should be affordable to people. But more importantly, the pipeline. I mean, since the first antibiotic that was invented, the penicillin story, I think there has been a stagnation in terms of the pipeline of churning out new molecules. And I think the main platform that has been created by WHO is not just in terms of the diagnostics, but also in licensing new molecules that come into place. So as we continue to educate, according to this year's theme, we must actually come out very strongly to go down to the communities. And I think the commendable work by FAO and other partners in establishing the CASIX, I think this has been tremendous, which is nestled within the One Health framework. The 18 or so CASIX, I think they are working in terms of piggybacking on the efforts that have been accrued for many years by CDC starting this initiative of the county One Health units. So having said that, I think we will continue to advocate for more resources as WHO, but also we'll continue to engage high-level policies so that we act now to end the silent pandemic of AMR. Thank you very much.
Thank you. Representation from WHO. Lastly, we do have environment, representative from UNEP. Do we have a representation from UNEP in the house? Mm-hmm. There's one. Okay. So, any other partner in the house? Sponsor? That would like to say a word before we close that session. Thank you so much, and I think we are going to move to the next schedule on the timetable. So I'll hand over to Dr.
Thank you very much, various partners, for your remarks. We want to now progress to the next level of speeches. I want to take this opportunity to invite Dr. Robert Onsare from Kemri to come and give his high-level remarks. Karibu, Daktari.
So colleagues, all protocols observed. Actually now I was going to make a speech, but nevertheless it's a great pleasure. So on behalf of Kemri, my name is Dr. Robert Onsare. I'm currently heading the One Health Approach research program, and which we're focusing a lot on antimicrobial resistance. So it's our pleasure to continue partnering with the World AMR Awareness Week. And I want to associate myself with the remarks that were made earlier by my colleague, Dr. Olale Paul, with whom we form a consortium, the Rocket Project. So the Kenya Red Cross Society is part of the consortium, part of the Rocket Project, and they're leading the component on awareness. And as Kemri, we're focusing mainly on looking at the lab quality management system. From the presentation that was made earlier here by Dr. Omona, it was very clear that quality, lab quality, you want to be sure that the data that is coming from the lab is actually data that you can be able really to make decision on. So as Kemri, we are leading the effort in terms of taking the labs through their journeys they've had through subscribing to external quality AQAs, and we are implementing this in 9 health facilities under the Rocket Project, and we are happy to be able to partner in that manner. We were also part of the Fleming Fund, and I want to associate myself with the remarks that were made by my colleague, Dr. Bliver. We were the forefront in terms of building capacity for a number of labs. We took them through the whole spectrum, right from sample reception, sample identification, antimicrobial suspect testing, and also reporting. And so this was during the Fleming Fund. And so we're happy to have also partnered with our consortium partners in that manner. So it's indeed a great pleasure to be part of this, and we are happy to continue collaborating really in various ways to come up with ways we can be able to mitigate AMR. I want to reiterate also a comment that was also made by previous speaker in terms of really urging the government to be able to prioritize in terms of sustaining this. When you look at the labs, and I think my colleague Dr. Mbajo mentioned this, when you visit some of these labs, quite some work has been done. We've had renovations in these labs, we've had the equipment being purchased, but then you don't want to really ask yourself what will happen, for example, if these partners really leave in the next months or years or so. Really, I want to urge the government to prioritize in any way they can be able to support actually efforts that are geared towards mitigating AMR. With those few remarks, I want to stop there. Thank you very much for your attention.
Thank you very much, Dr. Onsare. Your work at Kemri is appreciated. We would like to hear remarks now from Calro, Dr. Monica Maichomo. Welcome, Dr.
Hello, good afternoon, colleagues and everyone in the loop. Thank you very much, our chief guest and all our high-level delegates and partners and colleagues in the different entities that we interact and addressing this very prestigious topic of AMR. I am delighted this afternoon to be part of this meeting and gathering on behalf of the Director General in Carlo and some of my colleagues in this room. We are from the Veterinary Research Institute, really where the animal health work is happening in Carlo, and therefore the most relevant to be in this meeting. So we are glad to be part of this journey addressing the AMR in this country. And I know most of us will remember and know that Moguga, whenever you hear that name, it's a blood name really in Kenya and also globally, because recall the story of the leader pest eradication, and Moguga was a reference lab by OIE then. Therefore, we have good things, we have laboratories, we have structures that can really contribute in a big way to this agenda. And we are very much glad right now to be part of the collaboration within the Fleming Fund and to avail our laboratories as part of one of the sites for surveillance, particularly for the daily value chain. So, and going forward, we have our young early careers, and we have really been doing some stuff, but not within this collaborative consortium, and we are glad that even some of our early careers will be presenting some of the work, the data that we have been generating, and that we shall continue to generate so that we can inform the research agenda. I know we are part of the government, and I pray and hope that Voice of Reason will one day ensure that the big things we are doing in our laboratories, equipping, that it will not be an exercise in futility, because if well planned, if well deliberated, we can very easily deliver a sustainable agenda for this country and even to resonate with the region as a force to reckon with. We are glad to be part of this AMR Awareness Week. Thank you very much.
Thank you very much, Dr. Our next remarks will be from the representative of the CEO, Kenya Veterinary Board, Dr. Benson Kibore. Karibu, Doctor.
Good afternoon. Our chief guest, representing the PS, State Department of Livestock, the representatives from the DVS, from CALRO, the NASIC Secretariat, partners who are here. My name is Dr. Benson Kibore, representing the CEO, Kenya Veterinary Board, and I serve there as a director in charge of compliance, enforcement, and market surveillance. It is a pleasure to be with you here today. And basically, to exert one of our roles as a board, and I think where we fit in very well in this antimicrobial fight is Act Now. The board is charged with regulating the veterinary practice in Kenya, and as such, all veterinary practitioners are supposed to be registered and retained by the Kenya Veterinary Board. With this in mind, it is our expectation, as per the provisions of the Code of Ethics 2015, that our professionals are up to the task of judiciously utilizing antibiotics. One of the ways that we are implementing the issues of the Act Now is what is provided for in law. That is the issue of ensuring that each practitioner, each clinician implements the use of prescription writing. So that is one of the elements that as a board we are now implementing very aggressively. Speakers have talked about issue of sustainability. And let me tell you what we are doing to sustain this fight. Number one, the board has already hired a team of inspectors where I'm heading that inspectorate. And in the coming days, we're going to open up our regional offices so that we can devolve the function of regulating the veterinary practice. If you looked at the data, it is projected that AMR, and as it's seen in the data presented by Dr. Romona, is that around 10 million people are set to die by 2050. You know, that 10 million is, we can also be part of that here. Are you aware? So it is a question of what we do now that determines our reaching 2050. Those statistics are grave. The money involved, or in terms of losses associated with AMR, is staggering. 3.4 trillion US dollars by 2050. That is staggering. So what a board is doing is ensuring that we implement the law, the provisions of the law as it is, and I think you've seen in the previous days, the resurgence in terms of our action to ensure that we limit access of medicines only to registered professionals. So one of the things we're doing is that a lot of our practitioners were outside the regulatory framework. So somebody registers, but is not regulated by the board. So what we've done is to ensure that every of our practitioner is regulated. And so anyone who misses the 2025 register actually will have his registration certificate recalled. So that now we can differentiate between the people who are licensed to handle medicines and the people who are not allowed to handle medicines, what we refer sometimes as quacks. Medicines are tools of trade of professionals to handle infections and to limit the impact of pathogens. So when these medicines are accessed by unregistered persons, it not only poses a threat to the Kenyan people, but also access of international market through, it limits access of international market to our products of animal origin. So it not only endangers our lives, it not only endangers our existence, but also limits our economic power as a country. And that is the reason the board is actively engaging in this business, is actively instituting the speed governor to ensure that we limit access to medicines. I want to end, one of the things, if you go up country, and what has actually driven a lot of some of these AMR activities, and the silent pandemic that we are facing, is something, when you go to the village, you'll hear a farmer say, I want you to, inject for me this animal for something called climate. There's something inject called climate. So you do just one therapy, one therapy of injections of antibiotic, and that is it. That is how we've actually speeded the action of the resistance towards antibiotics. So today, on behalf of the board, I want to commit that we are in this journey together because it affects all of us. No one here is discriminated. It will affect all of us. So before it affects all of us, it is about what we do as professionals, as institutions of government, to ensure that we limit and reduce the speed at which we are seeing the emergence of the AMR. So the board is actively in this, and I can assure you that beginning the 1st of next year, we will even see a more resurgent board to ensure that we fix the animal health delivery services so that it is only the professionals and the professionals that have access to veterinary medicines. With that, I thank you and I wish you a fruitful World Antimicrobial Week. Thank you very much.
Thank you very much, Dr. Terry, for your remarks and for the great work going on. And next, we have the representative from the Director of Veterinary Services, Dr. Evans Muthuma. Karibu, Dr. Terry.
Good afternoon. Yeah, my name is Dr. Evans Muthuma. I stand here representing the Director of Veterinary Services, who could not be with us today on this very important occasion because of exigence of duties. And I am also here because I also head the division at the Directorate of Veterinary Services, which is called the Division of Veterinary Public Health and Animal Product. And as we continue, you note that we'll be talking a lot about veterinary public health, because these are veterinary public health issue, and also the issue of foods of animal origin. And I would start by saying that this is a very important occasion today, where we are celebrating the World Antimicrobial Awareness Week. And as the Director of Veterinary Services, we have been involved in the issues of AMR since the inception of this program. I don't want to go back to a presentation by my colleague, Dr. Romana, but this is one of the areas where the Director of Veterinary Services has been very, very passionate, very key in running the program. We have been involved in quite a number of activities. And the role of the Director of Veterinary Services is very clear. Number one, the DVS being the Chief Veterinary Officer in the country and a delegate of World Organization for Animal Health, and being the competent authority in animal health matters. So all the issues to do with animal health and anything related to the animals, that's the role of the DVS. So this is a role where he has taken it very seriously and has been involved in quite a number of programs. Because we have got our chief guest, I don't want to, because the chief guest is from the State Department of Livestock, and I know he's going to talk more on the issue and how we are, the ministry and even the State Department, how we are dealing with this issue. I just wanted to outline just two issues whereby the Directorate of Veterinary Services has been very much involved. As you know, the Constitution bestows the power of capacity building and technical support to the national government. And in implementing this activity on capacity building, the Director of Veterinary Services has been carrying out capacity building in the counties. And one of the area, the thematic area which we always cover when we are carrying out the capacity building is antimicrobial resistance and how to tackle it. We started last year, we did 4 counties. We built a capacity for 4 counties. We started with Kajiado, Nairobi, Nakuru, and Murang'a. This year, that was just last week but one, we also had capacity building for the 4 counties, of Machakos, Makueni, Kiabu, and Nyandarua. And in all this, when we are doing this capacity building, we have always had a presentation on AMR and also on farm biosecurity. Because as we're implementing the IPC, the role of how you handle the drugs, how you maintain your farm hygiene, how you implement the good agriculture practices, good hygiene practices, good manufacture practices, the impact on the usage of antimicrobial. So that's one area where we have done a lot, and we are happy we have had the support from our partners to implement that very important function. We also do another very important activity, which is sensitization of the stakeholders on AMR. And this one we have done by developing the information, education, and communication materials, which we do through the support of our various partners. And at the Directorate, we have got a section which deals with the issues of developing the IEC materials and also of dissemination. So that way, we have also contributed a lot in addressing this scourge. So what I would like to urge you, on behalf of the Director of Veneral Services, is let us take our part. Let us play our role. Each of us has got a role to play in dealing with this scourge. I think the numbers which have been given there, I have scared all of us. In 2050, you have 10 million deaths resulting from AMR. That one is scary. And each one of us has got a role to play in ensuring that we tackle this scourge. And it should also start even with us, even in our homes, even in our families, in our groups. Let us spread the message. I think the theme for this year is very clear, very, very clear. And this is what we should carry home and ensure that we spread the message, because let us act now, not tomorrow. Otherwise, we are in danger of being decimated by just AMR. So with those few remarks, thank you very much, and I wish you all the best as we continue celebrating this day. Thank you.
Thank you very much. It is indeed now my honor and privilege to welcome the Director of Health Standards, Regulations and Quality Assurance, Minister of Health, Dr. Charles Kandie, to give his remarks, and thereafter to invite the chief guest. Karibu Daktari.
So our chief guest, Principal Secretary for State Department of Livestock Development, represented by Jude Wasonga, Institute Director for Carlo Muguga, Dr. Monica Maichomo, Dr. Evans Mudama, representing the DVS, Dr. Benson Kibore, representing the CEO, Kenya Veterinary Board, Dr. Gabriel Aboge, representing Dean, University of Nairobi, Faculty of Veterinary Medicine, representatives of the government ministries, departments and state agencies who are around here, development partners and implementing partners who are here, AMR stakeholders, distinguished guests, ladies and gentlemen, good afternoon. So first, I want to extend my deepest gratitude to the organizing team led by the Ministry of Health, the Ministry of Agriculture, Livestock and Fisheries, Ministry of Environment, Climate Change and Forestry, and Ministry of Mining, Blue Economy and Maritime Affairs, the organizing committee, along with other partners who contributed to this event's success. I look at this event as soul-searching. We've come together to audit ourselves, to take stock on our ability to begin the process of changing the tide of AMR burden. and it requires us to look at that. So in addition to raising awareness to the public, to the communities, to the stakeholders within the distribution channel of antimicrobials, and also to the providers, this is the moment we need to look at. So we need to see where are we on this. So this bringing together all these players is a testimony to the One Health approach and what Ricardo of USAID talked about, multi-sectoral approach. So we need to act together or perish together. So where do we need to work on this? So a threat of AMR in one corner is a threat everywhere. So we need to begin to look at that to push us together. I'm good in starting or beginning an initiative. So from where I sit in the Ministry of Health as the head of Health Standard Quality Assurance and Regulation, where AMR coordination is domiciled, I'm ready to start the process. I'm ready to start the marathon, as indicated earlier, that we must begin with steps. And how do we do this? So I'm good in that. I'm not good in sustaining, not in the sense that when the programs leave, we don't have resources from the ministry, but we can work hard on that. So as we know, antimicrobial resistance is the most challenging public health threats, rooted in sectors as diverse as health, food safety, agriculture, environment, and trade. It extends globally and nationally, with studies predicting that if unchecked, AMR could cause up to 10 million deaths annually and reduce the global GDP by 3% by 2050. So 2050 is not very far. So we need to begin the process to see what can we do for that. I wanted to give an analogy of, I am a fan of boxing. The boxing where you hit one, you punch one another on the forehead. And if possible, you also punch yourselves on we call them the body works. So in boxing, so AMR has, we were very good as human beings in addressing infectious diseases through the microbial. So we've been punching them, but they are now punching back. So if we need to start responding. If you are punched continuously and you don't respond, what will happen? You'll be flawed and we'll have no medicines to act on this. So we are now at round 4 of the boxing match. We've started. We don't want to reach round 12 before we do something. So we need to begin working on this. So this trend risks reversing our hard-won gains against infectious diseases and threatens advancement in modern medicine. Further, as international travel and trade continues to grow, unchecked AMR could jeopardize the achievement of sustainable development goals and the attainment of the universal health coverage. So, as noted by the various speakers, the complexity of AMR underscores that no single department, organization, or county can address it alone. Effective containment and prevention require collaborative action across multiple sectors, disciplines, and stakeholders. This reality is underscored by the collaborative approach embodied in the implementation of integrated projects and guidelines developed by the various stakeholders, including those who are about to launch today. So I urge upon the development partners. I know we have got the tripartite team, the secretariat. I know we have all the players together. Let's not leave anybody behind because we need to work as a team. So the government has joined regional and international efforts to reduce AMR and ensure future availability of effective antimicrobials. Our national responses are centered on implementing sustainable measures to curb AMR emergence and spread, guided by One Health approach. These One Health ministries have worked together to implement AMR policy and an action plan where we have come up with a 6-point plan. So today, let's see at those 6-point plan, where are we? What can we do to be able, so that we can be ahead of the antimicrobials as they find other ways to defeat our fight against the infectious disease. So let's work on, look at that. So as I conclude, I want to recognize the importance of sustained government resources, both financial and human, in the crucial effective implementing, monitoring, and evaluating this multi-sectoral intervention. So the Ministry of Health, and we have heard your call, that what are we doing as ministries of health, as the other ministries, we need to start putting our resources together. So if it is possible, I will be calling upon my colleagues. We can develop a cabinet memo for all the ministries and come up with a budget plan that can be given at a high level. So that is my urge. I'm good in starting, so be ready. So if you see me knocking on your doors, let's work on this. We will be ready to do that. So we will be. So we will, in terms of AMR policy and national action plan, we want to receive resources towards implementing in line with the political declaration of UN General Assembly high-level meeting on antimicrobial resistance this year. The support for our development partners reflects a strong commitment on collaborating with the government to achieve policy goals for the benefit of all Kenyans. So with those few remarks, it's now a pleasure to invite our chief guest to give his keynote address. Maybe we can do that one by standing up, and we do makofi ya kilo moja. Karibu, our chief guest, to give us keynote address. Welcome, 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 welcome. Welcome. Funga. Fungua.
Thank you very much, Dr. That reminds us of where we were. I'd like to, first of all, ride on Dr. Ramona's apology for those who are getting their voices back. I'm in that group, and I thought that maybe I'll be quarantined, but since I found that it was not only me, here I am. My name is Jude Wasonga. I'm a Senior Deputy Secretary, State Department for Livestock Development in the Ministry of Agriculture and Livestock Development. I'm here representing the Principal Secretary, Honorable Jonathan Mweke, CBS, who was supposed to be here, but due to another engagement, couldn't make it today, and therefore sent me to represent him. I'll go ahead and read the speech. I'm also challenged visually, so I'll also need some assistance from these gadgets as I go through my speech. This is a speech by Honorable Jonathan Mweke, CBS, Principal Secretary, State Department for Livestock Development, during the launch of the World Antimicrobial Resistance Awareness Week from 18th to 24th of November 2024. The Director, Health Standards, Regulation and Quality, Dr. Charles Kandie, Dr. Evans Mutuma, representing the DVS, Dr. Benson Kibore, representing CEO, Kenya Veterinary Board, Dr. Monica Michoma, Carol, Dr. Robert Onsare Kemri, representative of other regulatory agencies, representative from the quadruped, WHO, FAO, WOAH, UNEP, Fleming Fund, the University of Nairobi, development partners and other stakeholders, honorable guests, ladies and gentlemen. It is a great honor to join you today as we gather to observe the World Antimicrobial Resistance Awareness Week 2024. Here in Kenya, this event, organized by the National Antimicrobial Stewardship Interagency Committee, highlights our collective commitment to address one of the most urgent global health threats of our time, antimicrobial resistance. AMR is not just a scientific challenge, it is a very real and present danger to the health of individuals, communities, and ecosystems around the world. It results from the overuse or misuse of antimicrobials, inadequate infection control, and the ease with which resistant pathogens spread. The impacts of AMR are felt across our health systems, our agricultural practices, and our environment. Ladies and gentlemen, agriculture is the backbone of Kenya's economy, contributing about 33% of our GDP and 60% of our exports. The livestock sector, in particular, is vital, contributing 12% of the GDP and providing livelihoods to over 50% of the agricultural workforce. Livestock farming is not just an economic pillar. It is a critical source of food security and social stability for countless of Kenyan families. Given the importance of livestock to the economy and rural communities, it is imperative that we manage livestock health with great care and responsibility. The livestock sector plays a crucial role in combating AMR by ensuring the responsible use of veterinary medicines. This will help mitigate risks to food safety, environmental health, and international trade. AMR threatens the growth and sustainability of the livestock sector, so the prudent use of antimicrobials, along with strong biosecurity and improved animal husbandry practices, is essential to maintain animal health and contributing to the global fight against AMR. As we mark World AMR and Awareness Week, we must also acknowledge Kenya's unique governance system where agricultural functions have been devolved to the counties. This structure places significant responsibility on local governments to tackle AMR. Each county plays a key role in protecting the health of our livestock, our communities, and our environment. Ladies and gentlemen, Kenya is making remarkable progress through the bottom-up economic transformation agenda, BETA, which aims to empower counties, communities, and citizens. It is crucial that our efforts to address AMR align with this vision. By strengthening livestock health, we are not only protecting animal welfare, but also fortifying the very foundation of our local economies. The Ministry of Agriculture and Livestock Development, through the State Department, recognizes the importance and urgency of addressing the growing global threat of AMR in all countries through a coordinated multi-sectoral One Health approach in the context of the 2030 Agenda for Sustainable Development. We remain fully committed to advocating for policies, guidelines, and regulations that ensure the responsible use of antimicrobials in veterinary care and animal production, as well as their safe disposal as encapsulated in the second National Action Plan 2023 to 2027. I commend the National Antimicrobial Stewardship Interagency Committee for their dedication in reviewing and developing the second National Action Plan, that is the one from 2023 to 2027, and its monitoring and evaluation framework. I also thank NASIC for preparing our country's position presented during the 2024 UNGA high-level meeting on AMR that provided for an opportunity for it to adopt a second political declaration to accelerate progress in addressing AMR at the highest level of political leadership. Ladies and gentlemen, to achieve the goal outlined in the AMR National Action Plan, we must work together. I deeply appreciate collaboration with key stakeholders, including the quadruple organizations, FAO, WHO, UNEP, and WOAH, through the AMR MPTF program, the UK government, through the Fleming Fund, USAID, FIND, ASLM, World Animal Protection, ILRI, WSU and CDC, civil society organizations, academia, the food and feed industries, and the pharmaceutical sector. Together, we are taking significant steps to promote responsible antimicrobial use, strengthen surveillance, and implement effective stewardship practices. Ladies and gentlemen, this year's theme, Educate, Advocate, Act Now, underscores the importance of raising awareness and taking action at all levels to address AMR. By educating communities, advocating for responsible antimicrobial practices, and taking swift, decisive action, we can reduce the threat of AMR in Kenya and globally. Through capacity building, knowledge sharing, and resource mobilization, we can empower countries and the communities to effectively address AMR within their own context. Let us act now with a sense of urgency and collective responsibility to find innovative solutions and reverse the growing threat of AMR. In conclusion, ladies and gentlemen, I urge all of us here today to live with a renewed sense of commitment, to focus on specific, actionable steps to combat AMR and safeguard the health of future generations. Thank you, and may our collective efforts guide us towards a brighter, healthier future for all. That is the speech by our chief guest for the day, who was the PS for the State Department for Livestock Development, Honorable Jonathan Omweke. Thank you for listening to me. Asanteni sana.
Thank you, our chief guest, Mr. Wesonga from SDL. And as we have heard, we need to bring the youth on board to combat antimicrobial resistance. During this week, we had a competition for the youth, and we are honored to have an award ceremony for the youth. I'm calling upon Felicitas Mutuma to come forward and take us through that ceremony. Welcome, Felicitas. And as she comes forward, let's give her a clap. Thank you.
Hello, everyone. How are you? All protocols observed. My name is Dr. Felistan Kirote from React Africa. So during this Waaw 2024, we engaged Kenyan youth on innovation competition on essays, and we had top 4 who did very well in terms of essays on writing on how they can come up with innovative ideas to combat AMR. And I would like to take this opportunity to call upon the following youths from Kenya that we are very proud of for being awarded the most innovative entry of the World Antimicrobial Awareness Week. So the competition was themed Educate, Advocate, and Act Now. It was also prepared by the Waaw Planning Committee of Kenya. So we have 5 certificates and also a trophy for the position 1, who I'll be calling them in front and requesting the chief guests for today to come and award the certificates to them kindly. So we'll start with Certificate of Merit for Felix Omondi Ochola. Felix Omondi, if you're present, kindly come. Kindly. So Felix, his essay was the most innovative. You can come to the front. Felix is from Kenyatta University. Let's give him a word of applause. To position second runners up, it was Nderitu Rosemary Wanjiru. Nderitu Rosemary is from the University of Embu. Thank you so much for participating. First runners-up, we have Lynette Lusimba. Followed by, so the first runners-up, there were 3 of them. We have Lynette Lusimba, we have Kathleen Ouma, and Alice Aoko Owiti. Yes, Alice. So Alice will be taking for the 3 of them.
So your clap has to be 2 times, 3 for them.
And our winner for the innovation essays, we have Paul Musili Mutemi. He has come out all the way from Meru University. Paul, are you? Okay, the winner is not in. We can have Ndege Ngere. Ngere, are you in? Kindly come pick up this trophy. He is the youth coordinator. He was among the persons who are coordinating this competition. is going to be taking for him. Let's give the winner in absentia. And let's continue encouraging the youths to participate in this fight for AMR, because they come up with really great ideas, and I'm really proud to be one of them. Thank you.
Thank you very much, Dr. Terry. It's great to see generation, is this Alpha or Z? Z participate this early in preventing and containing AMR. At this juncture, we want to proceed to the official launch of the Waaw 2024 and a couple of strategic documents that have been developed with the aim of combating AMR in Kenya. And I will invite Dr. Nkatha Gitonga to take us through this session. And as she comes, we will need a couple of us to be here to participate in this part of the program. We will request the chief guest to come to the front. We are also going to request NASIC representatives who are here to join us in front. Our sponsors, partners, those who have given remarks this morning, kindly come to the front as well, including the representatives of the various organizations who gave their remarks. We kindly request you to join us as we officially launch Waaw 2024 and the strategic documents that have been developed, I believe, over a couple of months or years that are aimed at helping us contain AMR in Kenya. Over to you, Dr. Nkatha Gitonga.
Yeah, so everyone just make your way to the sides of this lovely decorated structure. And we are all part of this, so the rest of the participants, you'll assist us with counting down so that our chief guest can cut the ribbon when we count down from 5, 4, 3, 2, 1, and then kata. Yeah? So allow me to, sorry. So let's split evenly. Let's have 2. All right. So there are a number of documents that are being launched. And I think we'll just mention them as we go through this countdown so that we see what's behind this. So participants, you indulge me and assist me in counting down. And when we count down from 5 to 1, we'll say kata. And yeah, you'll be able to cut that ribbon for us. Yes? Great. All right. So 5, 4, 3, 2, 1, kata. All right. All right, so as you heard, there were a number of documents being launched, but also quite importantly, there was the launch of the mobile app, which is the MOH Kenya Patient and Health Safety mobile app. So I would just ask you to turn your eyes to the screen so that we can just have a look at the official launch of that app, and then it will be followed with a QR code for you to be able to download. Yes, so can we have chief guest come and press the launch button for us from the... Today we've given you one. If you just come and press the launch button on the... All right, so let's count down for him again. 5, 4, all right, so this mobile app will be able to, you can just see the documents are all uploaded. There are about 20 documents that have been uploaded, and you can easily search for them using keywords. However, it's an ongoing process. The documents that are being launched today will be uploaded there as well. We'll provide a QR code for you to scan, but you can also download the app from sdms.nphl.go.ke. So once you do that, you'll be able to log in using your Gmail account, and then it'll prompt you to download the MOH version 1 APK. You accept permissions to install from the drive, and you install the app. Open the app, and happy reading. Thank you.
So feel free to scan the QR code from anywhere you are to download the app. You'll get prompted to install it, so accept the permissions. Then note that when you install the app, you're able to read the documents from the app, or you're also able to download the documents and read them offline. If you work in a part of Kenya where there's a limited internet connectivity, you have access to these documents on your hand at any time, and you're able to search by a keyword for any topic. Thank you very much.
Thank you. So I think we'll just have some photo opportunity there, and then I'll hand it back over to Dr. Collins. Thank you so much.
Thank you very much. Our guests, you may have your seats. We have come to the end of our launch this morning, the World Antimicrobial Resistance Awareness Week. I noticed some banners are missing resistance. So just a couple of announcements before I invite Dr. Emmanuel Tanui to give his closing remarks. As was mentioned earlier, we have some car keys here. It will be good if you came driving to go back driving. Those who are presenting in the afternoon, if you haven't sent your PowerPoint presentation, kindly do so. You should have received an email from me by now. But the email is amrsecke@gmail.com. And then after this, we're going to have lunch, and let us kindly be back by 2:15. Thank you very much, and I take this opportunity to welcome Dr. Emmanuel Tanui to give us his closing remarks. Thank you, Doc.
Good afternoon, everyone. So first of all, on behalf of NASIC, let me extend my sincere gratitude to all of us for taking the time to attend this national launch of the World AMR Awareness Week. Thank you very much for the commitment, for the insights that we have been able to share. The diversity of this gathering today really underscores the importance that we all place towards addressing the issue of AMR. First of all, I'd like to thank our chief guest, a representative of the Principal Secretary for the State Department of Livestock, other senior government representatives, our development partners, implementation partners, and all protocols observed. Thank you very much for your time, the time that you took to grace this occasion. Thank you for the remarks that have been made from all the partners. Thank you for the support that you have placed. I know we all face a lot of challenges when we are implementing activities, but we know with collaboration and partnership, we'll be able to address all these. So we need to carry on the call for advocacy that spearheads the reasons why we have our World AMR Awareness Week, not just this week alone. We have all year round for us to be able to conduct the advocacy, the education, awareness. I want to appreciate the work that the World AMR Awareness Week Planning Committee has been doing over the course of the last several months. They have been meeting every week since September to be able to make this day a possibility. We have had several subcommittees that have worked tirelessly to be able to make this launch a reality. We have subcommittees responsible for this high-level launch and resource mobilization. We have had subcommittees organizing the AMR Scientific Symposium. We have subcommittees organizing the advocacy and awareness who are responsible for designing the awareness materials. So all the banners, materials, the t-shirts that you see are courtesy of the work from the advocacy committee, and kudos to all this good work. We've also had the subcommittee on youth events, and as you have seen the awards that have been awarded, this competition was held courtesy of the work that the subcommittee oversaw. We also appreciate the counties. We have a number of activities that the counties have planned today and even the course of this week, and we really appreciate the collaboration from the counties because we know work and action happens at the county level. In the afternoon and tomorrow, we'll also have presentations during the AMR Scientific Symposium event, and we appreciate all those who have been able to submit their abstracts, and congratulations to all those who are selected. We appreciate the work that you have done and sharing the knowledge and evidence around AMR that is going to happen. We appreciate the support of the partners also who have made it possible for us to have this event, from the venue to the lunch, the awareness materials that we are going to use to create awareness around AMR, and even the support for the media breakfast that we had in the morning. I think this was a very good opportunity for us to engage together and find ways in which we can take the message even beyond the confines of this venue today. For the documents that we have seen here, I think the onus is on all of us now to disseminate these documents. Implementation is very important for us. Let us not allow these documents to exist within the apps and even our shelves, but it is really important for us to ensure that all stakeholders are aware about these documents. I also want to appreciate the other teams behind the scenes who are doing the live streaming, the photography, the hotel for hosting us. Thank you very much. I'm sure we have all had a good time, and we are going to, as we are going for lunch, we'd really want to appreciate all the work. So I think for us, the parting shot really is behind the theme for this year, educate, advocate, acting now. We are called to action for all of us to play a key role either at the personal level or at being able to mentor others, creating awareness about not just this week, the days ahead. Let us continue advocating for timely interventions to address AMR and even providing for funding. The time to act is now, and I want to reiterate the call that we had today in the morning from our colleague, Dr. Karis. AMR may be invisible, but I am visible. The time to act is now. Thank you very much. And just before I end, I want to welcome all of us to the afternoon session. We are starting a very interesting, vibrant, and engaging AMR symposium, where we have plenty of presentations, abstracts, and so forth. Otherwise, thank you very much to all of you. Thank you. All right, so I've been reminded that we need to do a group photo. Kindly persevere with us for just 2 more minutes for the chief guests. Our chief guests, the speakers who made the remarks, the partners, sponsors who made the remarks, please come to the front so that we do a group photo in commemoration of this launch. Thank you.
Excuse me, NASIC members, please come forward for the photo. NASIC members, eh?
So I think we can have the chief guest and partners first. The chief guest and partners stroke sponsors. Now that the stage is small, so sponsors stroke partners. I hope they're all visible. Okay, sawa. Now we'll have the chief guest and Nasik and the rest. Okay. Maybe the chief guest and Nasik members. The National Antimicrobial Stewardship Interagency Committee.
Another one?
I think
yeah.
Okay, thank you very much, our chief guest. Asante sana.
Umetuma
sana. Nafikiri una nini? Oh, sawa, sawa. Nimeshangaa because symposium and then you encourage people to join the symposium.
Just confirming then. I think when he comes.
Sawa. Kwa nimeona jamaa umenyamaza tu, haunijibu.
Unajua naangalia na mgoi.
Lunch is on second floor. I'm told there are many lifts. So it's the lifts this side. So people should exit this way. Yeah, but lunch is served second floor.
On our left, huh?
Yeah, so it's on your left, their right.
Yeah. No. I'll point, huh?
I think that's better, yes.
Excuse me? Okay. So we'll break for lunch. We are going to break for lunch. Lunch is served on second floor. The best way upstairs is on my left, this way. On my left, I hope everyone can see me. It's on my left. We can use the lift on our left to second floor, where lunch is being served. Thank you. So let's come back at 2:15.
Thank you. Yeah. Unfortunately, I can't stay for lunch.
And for the presenters, those who are presenting in the afternoon, kindly see
Winnie and Dennis.
Yes.
Daniel, sorry.
Yeah.
You said they come back at what time? Oh, I had 50. I had 50.
Please be back at 2:15. That is 2:15.
Check 1 2. Check 1 2 1 2. Check 1 2.
This must be Sarah.
Because you might need this mic for mic testing. 1 2 1 2.
Mike,
Mic testing. 1 2 1 2.
Such a rush, my baby, slow down, come find your love. I'm hoping you see me, come serve it up. Loving when you stir it up, that body belong on TV. Oh, this feeling I can't hide. You're feeling up my mind, and I just don't know why.
We have a poster session.
Okay.
Tunaona sasa sahi after lunch hawajafanya posters.
But watu zinao wanafanya.
But no, si wengi. So after Q&A, wakuja waeke posters.
Okay.
Ndio?
Okay. Good afternoon. We want to start the next session, so I'll kindly request people to get seated so that we start. Please, let's get seated so that we start. We are already late. Otherwise, I'll keep you here until I don't know what time. So please, kindly, let's get seated so that we start our next session. Please, for those who are standing and still doing posters, let's just sit and then we start, and then we'll have our poster time, I think, at the end of the session. If your friend is not there, please just look around who you are seated with and then invite them to come. If they're not there, just call them, tell them we are starting for the interest of time, so that we don't keep ourselves here for so long. Even as we wait for people to come, a quick update for the points, CPD points. I'm sure most of you come from different professions. We have Kenya Veterinary Board, and we have Vivian. Please register online with the link, and then now you can talk to her. And And please stay in for the session because she's going to be monitoring who is moving up and down. And if you're moving up and down, she may not give you the points. I think we also have the pharmacy one. Please confirm. Yes. So you also come from pharmacy, please, there's also CPD point. Register as well with the link that was shared. I think, start. Have you called your friends? We just start, eh? Okay. Do we have all the presenters for this session? We have Sarah is there, Edna, Kuba is here. If I mention your name, yes, thank you. This Wada Nasir Omar. Is Wada here? Is Wada here? Please raise up your hand tall enough if you're here so that we see you. Then we have Gavin Oragi. I saw Dr. Gavin. Then Anima Silma, she's there. Collins Keegan is a poster. Okay. And then we have Dennis Githiji. He's not there yet. Okay. Please get seated, we start. Please, Kamukunji is behind. Allow me to to make you sit down, and then we can do the posters and the interactions later after the presentations. So good afternoon. My name is Dr. Christine Bindio. I work for the University of Nairobi. I would like to take this opportunity to welcome you all to our World Awareness, MR Awareness Week, Kenya National MR Scientific Symposium 2024. Our theme still in alignment with the Waaw Week theme, which is Educate, Advocate, and Act Now. So I take this opportunity to welcome all of us. I know we have passionate people who are interested in AMR, and I'm sure we're doing AMR in different dimensions. And this is an exciting opportunity for us to share the evidences that we have, the new research that we're doing, what are the current exciting findings, what are the new approaches that we need to do so that we curb the spread of AMR. So we have a lot of presentations, and some of them are very exciting. We will have a keynote speaker. We have a keynote speaker who is going to give an interesting conversation on academia and the role of academia on AMR. We also have some work on implementation science. Tomorrow we'll do evidence, and I think we also have beyond antibiotics, and we also have some work on community engagement, youth, finance, and AMR and governance. So we have a number of exciting presentations that are going to keep us in the next 2 days, today and tomorrow. I will encourage everybody to participate, interact with in the discussions, interact with the presenters, and make some networks, because as we've seen today from our earlier conversation, AMR is all of us, and we don't want to leave anyone behind. We don't want to wake up from this tsunami that is looming one day and find that it is way too late. So it's time to act now, and we need to act with urgency. So with some housekeeping matters, we have our online then we can handle the questions at the end of the discussion. And then, what else? We also have our Twitter handles. Please, if you're in that generation, please share in X. I'm sure Space, I think that is the right term. You can tag us. This Waaw 2024, handle antimicrobial with care, educate, advocate, and act now. I think with that, I would like to invite the moderator of today for this session, Dr. Winnie, on stage to take it up from there. Thank you very much.
Thank you so much, Dr. Christine. So, good afternoon, everybody. Hi, simepata lunch. Maturudishe. Anyway, so you're all welcome to this afternoon session. And like Christine said, we'll have various talks from different presenters who will give us a brief on the implementation science aspect of it, which is the theme of this session. We we had from the morning session how as a country we've adopted the NAP, but we can see we are still lagging behind in terms of implementation. So we are hoping that the presenters will give us that, will provide us with that framework of the evidence-based research and the outcomes of some of the things that they have undertaken. So allow me to welcome our keynote speaker, Dr. Sarah Kindiki, and antimicrobial stewardship. Her major scholarly contribution is in her role in adding information on possible sites for mitigation to minimize risk of contracting hospital and community-acquired Pseudomonas aeruginosa infections, and on guide to treatment regimes at the Kakamega County General Teaching and Referral Hospital, and appraise prevention measures and patient care in clinical environments and prevent AMR transmission. She currently serves as a lecturer at the University of Nairobi, at the University of Must. Karibu sana daktari. Let's give a hand of applause as she comes.
Good afternoon, everyone. Thank you so much, Daktari, for that introduction. I want to thank NASIC because of inviting me here. Thank you to the organizers. I want to say thank you even to the chief guests in absentia, and other VIP who are around with us in absentia, and those who are in, other stakeholders, and all other partners. I say good afternoon again. I serve at Masinde Muliro University of Science and Technology. It is a university in Western Kenya, in Kakamega town, a university of choice. It is a university where everyone is valued and everyone adds value to what he or she does in that university. Masinde Muliro University of Science and Technology is a role model in fighting against AMR, and I am going to share a few slides on the role of academia in mitigating antimicrobial resistance. And these are perspectives from most. So AMR, as been said by most of the speakers, my predecessors, is one of the most significant global health threats today, and it impacts not only to health systems, but also economies, especially in resource-limited countries like our country, Kenya. And this chart describes the antimicrobial resistance chain along the food chain, which has been talked about so much. So I may not dwell much on the chart. Shows how antimicrobials are given to the animals which we take. The animals drops the organisms which develops resistance inside the animals, and we feed on them, or contract these organisms which have already developed antimicrobial resistance, and in the process we get sick, and this sickness at times leads to long stays in the hospitals, leads to drainage of our finances and all that. So this has been discussed before. Maybe to describe the burden, it has also been described, and this is a chart actually touching on the deaths by AMR, and the burden which is associated with the crisis, which actually calls for attention. Having said that, maybe we can, I can just mention that the common pathogens that are associated mostly with antimicrobial resistance, especially in human, pathogens like Klebsiella, pathogens like Escherichia coli, pathogens like Streptococcus pneumonia, pathogens like Streptococcus originals, Staphylococcus aureus, and Salmonella typhi, and many more, like Pseudomonas aeruginosa, which are very well emerging, and so on and so on. There are almost about 12, which I think the WHO has already published, and this is a pathetic situation, and we must deal with it. Now, the role of academia in AMR mitigation. Now, universities play a central role in fight against AMR, Masinde Muliro University also included, and many other universities and other colleges. But per the university, we lead in research. We lead in research. We train future leaders, even the leaders who are our bosses here. They go through the university education. And we also foster innovative solutions to this growing problem in actually 3 key areas where the universities are actually the hubs. They are hubs. They also develop solutions and also train future leaders. Apart from these 3 major ones, the university also goes on and address the extension. The extension whereby we need to collaborate with other collaborators to be able to extend the knowledge that is gained or extend the innovations that we have in the community. And this, we use the hospitals which are connected, or they have collaborations with the universities, and so on and so on. So there is a lot of research which undergoes in the university, especially most, and this is actually to impact or to bring about development of new tools, policies, and even regulations to counter AMR. There are studies which go on in the universities which are actually in accordance with relevant national and international governance arrangements on treatments and prevention for common bacterial infections. There are other research which actually will help us, to give some evidence generation of filling the gaps in knowledge, dissemination operation research, coordination, and collaboration. All this goes on in our universities. Economic research also, which includes the development of models to assess the cost of AMR and also the benefits of the action plan that is actually put there by the government. We also develop standards for collection of data and the reporting of AMR in human health, especially in collaboration with the hospitals that we have MOUs and the ones that we use when we are training our students. In education, training, capacity building, and advocacy, we are saying that the universities basically are supposed to review their undergraduate programs or curriculums and postgraduate curriculum and incorporate AMR appropriately. And this has been done in some of our curriculums, especially for students who are taking medicine in the universities, students who are taking medical laboratory sciences in the universities, students who are taking nursing in the universities, students who are doing public health. All these has been, revised and has been upgraded or has been reviewed to incorporate the essence of, AMR appropriately. And therefore, these are techniques which are actually taught in the routine education and even practice in our teaching laboratories. In the university, we develop training curriculum and conduct short training courses, workshops, seminars, CMEs, and even build capacity. And we share the best practices. And in advocacy, we also try to get involved. And looking at this, the importance of implementation science in AMR mitigation, there are pillars, or rather, there are those pillars which actually we have adopted from the global perspective, from the National Action Plan, including the prevention, the data generation, the awareness and behavioral change, the areas, and the access and conservation. All this we have trying to put in place as we take through the students through their curriculum. Some of them financed, others people are volunteering to do this work, to give back to the community. So the implementation science plays a very crucial role in the mitigation of antimicrobial resistance by bridging the gap between research findings and the real-world practice. And it helps translate policies and interventions into practical actions. What is the current AMR landscape in Kenya? This is a chart showing the fragmentation. In fact, in Kenya, today we face a fragmented AMR landscape with significant gaps in data, in policy, in implementation, and infrastructure, owing to these areas, like because probably the structures are not very well laid down, we have the porous borders which allow counterfeit medicine, which actually worsens the AMR, the self-medication, which actually the self-medication in poor urban areas, which fuel antimicrobial misuse, and so on and so on. We have limited laboratory resources in healthcare facilities, which drive AMR spread, and so on and so on. Also, we are saying that the challenges we have, that is the challenges of limited resources, public awareness, and healthcare gaps, The opportunities for the academia support in Kenya's AMR strategy also are attributed to AMR cases. And in this, maybe I would mention that some of the challenges, like the universities that we have, we do not have a very clear collaboration with the national government, whereby you find that we have so many, work that we do as universities, and we keep that work, which actually does not reach very far or does not disseminate very well because of such challenges. At most, we are dedicated to addressing AMR through research, teaching, and even extension. And our initiatives actually align with the Kenya's national strategy to combat AMR. So I will share a little of, or just to mention about the initiatives. Sometimes we organize, not sometimes, but in the curriculum. You'll find the university curriculums, we have organized some kind of activities like outreach, where the students that we are training, both the public health, the MLS, the nurses, even the doctors, we have organized this outreach of people. We give pro bono services to the community, and we teach them what we know about AMR, and the students are mostly used to go to the community and give this back to the community, or be able to do those outreach. To mention a few research which has been done in Masinde Muliro University. This is one of the research which has been done by one of the master students whom we have seen, we are in the same research teams, because we have a bit of research teams which are well organized to be able to have objectives or in research meant. And we have conducted very impactful studies in microbiology and public health to address AMR, and these contributions provide insights and solutions tailored to our local challenges. And this recent study by this student, Nick, focused on Staphylococcus aureus, and this was done at Kakamega County General Hospital from surgical site infections. And this was to understand their AMR to first-line post-surgical prophylaxis. And you can find that these are very insightful results that we have, and probably they have not gotten out. They are published, yes, they're in the databases, and online you can be able to get, but that kind of mitigation or that kind of going down to the community has actually not taken place because of one reason or another, and mostly it's because of the challenges we have in resources. We also have some of very senior people, like Dr. Sifuna, who is the Dean School of Medicine at Masinde Muliro University, who did an investigation into the presence or absence of AMR and virulence associated genes in a collection of some clinical and municipal wastewater Escherichia coli isolates from Kakamega, Western Kenya, and he had very interesting findings here. In that clinical and wastewater isolates, each contained a very similar mean number of antibiotic-resistant genes. This is a very insightful information, which probably, if put into practice or put into consideration by the mitigators of the AMR, the resources or the funders, then we would be able to do even further investigations on these genes and try to, correlate the two. Others in access microbiology, the likes of other staff who have done a lot, the whole genome sequencing and genotyping Klebsiella, pneumonia, multi-drug resistant hospital isolates from Western Kenya by Victor, the study which actually focused on Klebsiella from patients seeking treatment for various ailments, including respiratory tract infections, urinary tract infections, the sepsis and wounds at Kakamega General Hospital. There are so many interesting results that I will not expound on this chart, but basically these are results which shows, or they're actually articulating the organism's propensity to accrue antimicrobial resistance and virulence determinants. There are more work, around 4 papers, which are going on AMR, and this have been my work as a university staff, where we have done a lot on genomic analysis of multi-drug resistant Pseudomonas aeruginosa. All this is isolates recovered from patients in Kakamega General Hospital, where there is it is a work detailing on the Pseudomonas aeruginosa as a multi-drug resistant organism, which is isolated within, which actually shows some interesting genomic characteristics which fuels the organism's antimicrobial resistance at the hospital. Now this looks very fascinating. It looks very interesting, where you, even after research, you get some novel organisms with, similar genes with what has been reported, has been reported as maybe, multi-drug resistant organisms, has been reported isolated from patients in our local hospitals, and you isolate such a novel organism. We do not understand, or we do not know what is the future in case this organism goes or spreads in the environment or goes into the community. We do not know what it is going to cause. So it is a bit alarming. And these are charts just showing the resistances, including the resistances to disinfectants, resistances to major antibiotics that we use in the hospitals, including the macrolides, including the ciprofloxacin, including so many drugs which they are resistant, showing that this P. aeruginosa is really showing a lot of variation in its genomic, in its genes, and it is evolving, and it is actually developing resistance each and every day. And also, we have come up, or we have seen the performance of the mechanisms and to which these organisms are developing each and every day to counter the antibiotics. We have done reviews also, but I will not dwell into that. Maybe the next thing I can talk about is that most collaborates with, and also we work with partners. Masinde Muliro University has been able to collaborate with partners from University of Cambridge, from South African universities like Pretoria, where we have a very deep research involving the students, the master's students, the PhD students, the staff, and there is a lot, gotten from these researches. And collaboration is actually the key to amplifying our impact in research. And they work with government agencies also, and other international organizations to tackle the AMR from multiple angles and institutions, including these universities that I have mentioned. Now, these are some of the team workers, and there are so many. These are just part of the team workers whom we collaborate with. And maybe before I finish, this is one of my last slides, I would say that in extension, which I haven't, I do not have a slide for that. In extension, Masinde Muliro University of Science and Technology and other universities, of course. I talk more about Masinde Muliro because that is where I work. And we have partnered. We do a lot of partnerships, including, applying for this partnership. Like we have partnerships with the Commonwealth Partnership for Antimicrobial Stewardship, where we after applications, you can be able to secure some funds. Like we have a very big project, which is funded by Tropical Health Education Trust Fund, which has actually helped a lot in helping the Kakamega General Hospital, Kakamega County General Hospital, in implementing the antimicrobial stewardship, where we have extended our work there. In fact, we are doing some innovations to come up with some diagnostic tools or diagnostic kits. We have also secured some very nice and important equipment, like the VTech machines for culture, identifications of those organisms, and so on and so on. We have also put across some clubs, especially for the students who are doing masters, who are doing medicine, who are doing public health, who are doing nurses. We have made some clubs where we try to make them aware of AMR and even go for sports and, compete and all that, prize givings and all that. All that in form of, an extension, as a university, working with partners, trying to extend and give this back to the community. Now, despite challenges, I am finishing. Thank you for giving me another 1 minute. Despite the challenges, there are many opportunities to lead in AMR mitigation, and this includes expanding our curricula and fostering interdisciplinary collaborations, and evidence-based policies are crucial in combating AMR. Academia must give these policies by providing robust data and insights. So these are future directions for most in AMR mitigation, where we are planning a new AMR research focus and expanding laboratory capacity. In fact, we want to have a hub in Masinde Muliro University. Of course, after applying for some grants, if all goes well, we'll have a hub for AMR at Masinde Muliro University. And therefore, these efforts aim in position most as a regional leader in AMR solutions. Thank you so much for listening. I beg to stop there.
Thank you so much, Dr. Sarah, for taking us through the role of academia in combating AMR. I think one of the key things is in terms of training and capacity building, which is one of the key pillars of this year's theme on education. So I'd like to open the floor for questions directed to Dr. Sarah. Let's kindly check if we also have questions from the online platform. Any questions for Dr. Ari?
Thank you very much, Dr. Sarah, for that wonderful presentation. I have just one small question. I know, and from the university, we've produced a lot of research and we publish all the information. But what comes to the community? What do you give back to the community? And when it comes to innovation, do we have something to show that we have innovated something? And I am speaking to myself as well because I'm also in academia. Thank you very much.
Thank you, Dr. Ari, for that question. Let me approach it like this. We have tried, as a university, what we have done research on. we try to take it by way of mostly looking at the hospitals which are around us, collaborate with them, and see whether we can be able to intermingle with them by way of, like, we have some staff who are included in the CASIC, including even those who are, other cadres who are not medics, like those who are, campaigners for Jesse, the inclusivity of social classes and all that, and see that the mitigation that these hospitals are doing by, holding those CMEs, holding those awareness. Like today, the way they are doing the awareness, we have university staff who get involved in these committees, and they contribute a lot, of course, by way of the awareness and selling what is on the ground or what has been researched. Thank you.
Any other question?
Allow me to ask the professor, by a like note, English people say behind every successful man is a woman. Are you related to Professor Kidiki, the Deputy President of the Republic of Kenya? Then the scientific question is, you repeatedly seemed to say that Pseudomonas, the P originosa was really a problem in the western part of Kenya. How is it in other parts of Kenya or in other reference hospitals? Thank you.
Thank you very much. I just have one question. Thank you very much, Dr. Sarah, for that insightful presentation. The universities conduct a lot of research and generate a lot of data. I don't know, in your view, what do you recommend how we can link data or findings from the university together with actual implementation from, for example, interventions that are being carried out from, let's say, for example, NASIC. How can you be able to utilize that data to make meaningful interventions for us at the governance and coordination structures? Thank you.
Thank you for that wonderful presentation, and Dr. Sarah, we really appreciate. Mine is just a follow-up with what Dr. Tanuya said in terms of intervention. You've told us that this Pseudomonas was an issue in Western Kenya and in the facility that you are doing this work. I'm just wondering what interventions did you link up with the facility to make sure that this kind of isolated organism does not spread, because it looks like it's a serious problem. How do we mitigate that? Thanks.
So I think we'll allow Dr. Sarah to answer those questions.
Yeah, thank you, Dr. I will start by answering the question on P. aeruginosa. There is not much data in the county, that is Kakamega County General Hospital, Kakamega County, as a whole. There's no much data which has been done on Pseudomonas aeruginosa. And we started with the CGH, which is close to the university, just to get isolates from the hospital and see what kind of data we can have for AMR, for antimicrobial resistances. So there were other areas which we actually wanted to, to get samples from. Those are the environs around the hospital. But we found out that most of the patients, in fact, in those areas, most patients are sent in Kakamega General Hospital because it is the only good or big hospital that they can be done surgeries. So this Pseudomonas aeruginosa was actually done on surgical wounds only. So there are other areas which actually have not been researched on, and we intend to go further and also go further and see even to those other areas which we do not look at. In fact, the P. aeruginosa from Kakamega County and the environments of the patients who are coming there was so resistant to amikacins until it is a worry, because amikacin is one of the drugs that are good in treatment of such organisms, and it was good in meropenem, which actually tallies with those other researches. Now about the link, about there are a lot of work that is done in the universities. The literature is actually published and is available. Yeah, we can be able to get it. But from my view, I would say that if we would have a database, maybe for all the universities that are involved in this AMR, and we can have a database to deposit this work, where we can actually be able to be retrieving for action. Anything that is recommended, we can do an action plan about it. Then it could be good. I think the fragmentation, because if you look at the universities, the University of Nairobi have their own data in their archives, in their libraries, and so on. Masinde Muliro has their data. So there's a lot of fragmentation of this data. If the government, by way of, if they could be able to, we could be able to have a common database where we are putting our information, then it could not probably be a very big challenge. That is my thought, and it can be corrected. Now, the interventions about, what we have found, the AMR or the antimicrobial resistances that we have found in this county, some of the interventions that we are trying to do is to deal directly with IPC, where we have trying to form some CMEs, some awareness. We have workshops. We have trained even over 300 people in some surrounding hospitals. That is in collaboration with the hospital, CASIC, the county antimicrobial stewardship. We have, and also the mitigation team in the hospital. We have involved the educators at the university and the hospital and the county, NASIC, and you have been able to train most of the people and in those rural setups. And basically it's on IPC. We have trained them on how to even develop their own antiseptics, their own disinfectants, and so on and so on. So it's a matter of awareness and taking concerns with IPC. Now, the last question is about the relationship. I don't, yeah, I can choose not to answer.
Yeah, you can choose not to answer. Yeah, so thank you so much, Dr. Sarah. So I think we can give Dr. Sarah a round of applause. Asante sana. So our next speaker is Edna Kubai. And Edna is from Nanyuki County. So she's going to give us a case study of Nanyuki County in terms of implementing some of the intervention strategies. So, karibu sana. You have 12 minutes to do your presentation, and we'll have a Q&A session at the end. Thank you. So kindly just note down the questions and we'll address them at the end of the session. Asante.
Good afternoon, everyone. My name is Edna Kubai. I am from Laikipia County. I'm a pharmacist by profession, a research pharmacist, and also I double up as Laikipia County AMR focal point. No, I'm not affiliated to the Kapenguria 7, just to make it clear. So we will be looking at the impact of intervention of antimicrobial use in the inpatient at the Nanyuki Teaching and Referral. Sorry. How do I navigate? It's not moving. It's not connecting. It's okay. So I move here. Yes, just check. Yes, it's connected. So apologies for the technical hitch. It's important to note that for the disclosure is that there's no conflict of interest, and this study actually we were funded by the Commonwealth Pharmacist Association, Antimicrobial around the second call of grants by also the Tropical Health Education Trust Fund, which is now called the Global Health Partnership through the Commonwealth Pharmacist Association. So today in the morning, many of the keynote speakers talked about how AMR is, actually we do no longer identify it as the silent pandemic. It's here with us. And in 2019, studies show that 4.95 million deaths were associated with bacteria antimicrobial resistance. And also by 2050, we will be losing 10 million people annually. And as the key speaker in the morning said that me and you could actually be one among the 10 million. So increasing antimicrobial resistance has complex causes, but in part of it, it's due to improper use of antimicrobials both in human health, in animal health, and also in the environment. We can also not ignore the aspect of infectious prevention and control, as well as waste disposal. Data on the prevalence on antimicrobial use in the hospitals is scanty, especially in the sub-African region. We all know how it is very tedious to carry out point prevalence in the entire hospital, both at the outpatient and the inpatient. So our study objective is to assess the impact of antimicrobial stewardship, interventions on prevalence of antibiotic use at the Nanyuki Teaching and Referral Hospital in patient setting. So what we did is that we had a pre-global point prevalence study that we did on August 2023. And then we had a whole year of interventions that were actually low-hanging fruits, because also costing is an issue, but also keenly looking at impactful and also sustainable intervention. The number of interventions that were implemented were also highly advised by the study that was done at the because so that we can know which areas in the inpatient that needs to be focused in, and then also now doing the post as an audit to see if the impacts were actually sustainable and that they were very impactful. So if you've come across or you've come across the global point prevalence study, it's usually only the patients that were admitted at the hospital at the day of the survey at 8 a.m., where we do the study on that particular day at that particular ward, excluding day patients. Day patients can be renal patients, can be day surgical patients, and it's inclusive of all patients, but I will get more epidemiological now. The numerator is the patients that are on antibiotics, and the denominator is all patients who were in the inpatient at that particular day at 8 a.m. So our methodology, as I said earlier, were the interventions that we did. We did 12 weekly training sessions developed in multidisciplinary AMS, who we identify them as AMS champion. The AMS champions are inclusive of a consultant, prescribers, both at the clinical and the medical officers. Then you also have pharmacy department staff. We have key people also in the AMR field, which is the clinical microbiologist. We also have the nursing team, who are part of the multidisciplinary training session, and also the public health. Last week we learned that we can't say training people for 1 week is a training, so we called it sensitization. So we had a 2-day sensitization and awareness for over 100 multidisciplinary health care providers, that we did trainings on sensitizing them on the AMR and also the AMS audits that we have been doing, and what are the interventions that they themselves helped us to develop, because AMS being a behavioral change aspect in health, you have to let people make interventions, and so that they can feel a sense of ownership of the intervention. Because this is also a grant, we were able to get funding on the consumables. The lab consumables for culture and sensitivity don't come cheap, and this has been quite a game changer for us, because now some of the patients that come in, we make sure that we withdraw blood before introducing antimicrobials. Then we also have done the WHO aware categorization, where we make sure that the access, watch, and reserve drugs are keenly followed. Also very key is that we had a privilege to go and do benchmarking for a whole week in the UK, and we were able to attend the AMS ward rounds and have a feel of developing nations' AMS ward rounds. We also have AMS AMR fellows from the Commonwealth Pharmacists. I'm actually one of them. And what this has done, it's a very impactful strategy, because we are able to run, let's say like one of us is in charge of the AMS ward rounds on a weekly basis or a monthly basis. And then the other one also, we can see from our posters, is one who does the One Health aspect of AMR. So they say a picture speaks 1,000 words. These are pictures on trainings, benchmarking. Also, we have very good buy-in from the leadership at the county level, and that's why we are able to do great impacts on AMR and AMS. So in our results, in the prevalence in August 2023, which was the baseline survey, was at 53.3%. And because of the interventions that I discussed earlier, we were actually very impressed by the results, and we were able to see a 28.3% respectively, which shows a 30% decline. Graphically, this is showing even which departments. The overall inpatient had a 58, the percentage that I talked about. Surgical prophylaxis, because we had very good buy-in from our consultants, who are also very open to AMS ward rounds, but also not forgetting the kind of challenges that we face because of lack of guidelines. And also OBS-GYN, there was a high decline of antimicrobial use in the adult medical as well, pediatrics, and even in the NBU. So a reduced prescription of following interventions is similar in other studies, that is doing the literature review, and it has been observed even elsewhere in Africa where such interventions have been implemented. The interventions, as I said earlier, is educating prescribers and other healthcare providers, also doing both prospective and retrospective audits, so that you can able to audit yourselves. Are your interventions working? What other changes can we have, or what other things can we have to introduce? And also having guidelines, they're quite a game changer because they really help in our audits. So in conclusion, there's a significant reduction in prescription of antibiotics, as we had shown during the results slide. And it's very possible that if you actually look at low-hanging fruits and also low-hanging but impactful and also sustainable intervention, definitely having the buy-in of colleagues and other healthcare providers, then the fight or the AMR curbing is quite possible. So I want to acknowledge Nanyuki Teaching and Referral, the Laikipia Health Services, Third Commonwealth Pharmacist, and our partners from UK, the Rural Global Emergency Care. Thank you very much.
Thank you, Edna, for keeping time. Our next presenter is Nasir Omar. Is Nasir Omar in the house? Okay. So Nasir Omar is going to give us a breakdown of AMS in Kilifi County. Karibu sana.
Thank you. Good afternoon, everyone. I'm privileged to be here today and part of this important symposium. I'm Dr. Warda Nasir. I'm a pharmacist working in Malindi Sub-County Hospital in Kilifi County and currently serving as the AMS focal person for the facility. So today I will take you through the finding of a survey about the perception of healthcare workers towards antimicrobial stewardship in Kilifi County Referral Hospital. So basically, antimicrobial resistance, it's been a global concern. I think everyone have been preaching the same since morning, and it has been declared as a silent pandemic. So with more than 1 million deaths which are occurring annually, and Africa being the highest burden because of the infectious diseases. So a study at Kilifi County Referral Hospital was done to assess the perception of the healthcare workers in an effort to streamline the local antimicrobial stewardship program. So the study objective was assessing the healthcare workers' knowledge, their behaviors, and their attitudes towards the AMS before the implementation of the AMS program and after the implementation. So it was a cross-sectional survey which was conducted before the AMS program and after the AMS program. So it involved a multidisciplinary team which assesses the knowledge and the pharmacists, the nurses, the clinician, the medical officer, and even the consultant and the medical interns. So we had 34 respondents during the first survey and 37 during the second survey. So semi-structured questions were used to assess the knowledge, the attitudes, and the behavior in regard to antimicrobial uses and the antimicrobial stewardship. So some of the results of the survey was about, the question which was asked was in regard to the AMR prevention. So as you can see, the first bar indicates the first survey, while the second one is the second survey. So there have been more respondents who recognizes the importance of proper prescribing practices, self-hygiene, and avoiding self-medication as key in the prevention of AMR. However, if you can see the last bar, there was a 3% of the healthcare workers who thought like the AMR can never be prevented. Well, during the second survey after the MS implementation, it was reduced to 0. So in regard to the knowledge on the uses of antimicrobial or antibiotics, so there was an improvement about the use of antibiotic. The question was assessing like what was the antibiotic used to treat for. So majority were for the bacteria, only pathogenic bacteria and fungi. So there was an improvement indicating that the use of antibiotics also treat all the bacteria, not only the pathogenic, even can affect the normal flora. Again, on the attitude about the antimicrobial uses, if you can see, it was assessing the attitude of the healthcare workers and part of the knowledge. So the question was about which statement was true or false. So the first one was about antibiotic usage in treatment of cold and flu. So you can see there was a 5.4% who thought the same and a 0% during the second survey who the misconception of the use of antibiotic in regard to the treatment of cold and flu was corrected. And again, there was a high percentage, the color green, which was, the question was about overusing of antibiotic can cause human resistance. So most of the people didn't understand, like, it's not the human who become resistant, rather it is the bacteria which become resistant and can be passed from one person to another, even though you are using your antibiotic properly. So that was improved. So in conclusion, the MS intervention improved significantly the perception of the healthcare workers in regarding to the antimicrobial uses and generally the knowledge about the AMR. So it highlights a lot of progress in regard to the prevention of AMR, where there was recognition about the good hygienic practices, avoiding self-medication, and good prescribing pattern. So the main thing was about tailored educational, which was involved in different departments. Each department, there were CMEs which were conducted in different locations, targeting different healthcare workers. So it was a multidisciplinary collaboration, and a robust antimicrobial stewardship program is very essential in combating this AMR. So I'd like to acknowledge USAID, MTABS, AMREF, and Kilifi County. And lastly, I'd like you, to all of us, I'll urge everyone to be antimicrobial stewards. And antibiotic, we should always know antibiotics aren't always the answer. When we have to think twice and seek advice before we use them. Thank you.
Thank you very much, Nasir Omar, for that wonderful presentation and also for keeping time. So I hope you're noting down the questions. Also, the guys on the online platform, just keep the questions for the last session. So I'd like to invite Gavin Orangi, who's going to dive into the role of digitalization as a strategy towards improving AMS. So, oh, you're here, sorry. I'll waste time. Okay.
Good afternoon. I know we just had lunch, so watu wachangamke kidogo. Mine is on a different track. I'll be presenting on digitization of antimicrobial stewardship in a rural facility. So it's a good thing when you're talking about digitization and you're in mashinani. So thing is, I'll just give a brief introduction to what we did. So 2022, we did our first PPS. And when we did our first PPS, the overall antimicrobial use was at 48.2%. Then 2023, we did another PPS, and our antimicrobial use had gone down to 32.4% overall, that is. So that was a good thing, and we were looking at that and then thinking, really, we can do better than this, and probably we need to do more in terms of stewardship in our facilities. But looking back, we had several challenges, and we need to be cognizant of a few things. One of them is when you're talking about antibiotic use, one of the main problems that we had was irrational use, whereby you had your unnecessary antibiotics, incorrect dosing, probably patients who are getting inappropriate durations. I know for those who work in hospitals or labs in our country, probably a patient comes with a diabetic foot and then they are given IV flucloxacillin. Probably after 2 weeks, you just say CT therapy. So those are the kind of things that were there. We also noted a high use of things like ceftriaxone, so which were associated with irrational use again. I would like to point us out, I think when you go for a tea break, you can go at the back and look at the posters which are there. You'll note some of them are very interesting. There's a study on Kleb pneumonia which says there was a resistance rate of 78% to ceftriaxone, which is actually very worrying, and those are the kind of things that we need to look at. So high cost because we are buying a lot of ceftriaxone, but if you have that kind of resistance, really, what are we doing? There was lack of an audit tool that was to be used for assessing what? Antibiotic use and utilization in the facilities. So those are kind of the challenges that we had in our facilities. So for us, we thought of a solution in regards to digitalization. So in terms of digitalization here, we are talking about we do a ward round, but you have a digital tool that you can use to do what? Assess and also record whatever you're doing in terms of your antimicrobial stewardship practices. I know we do a lot in our hospitals, but how much of that do we actually record on a day-to-day basis? So this enabled us to do real-time data collection and monitoring. I'll take us back to what was in the speech of the chief guest. I remember it was Honorable Jonathan Mweke. I might forget, but I think one of the things that he said is this government is more of bottom-up, but most of what we're doing is top-bottom. So ideally, if you can do your ward round and do your interventions real-time, your AMS ward rounds in the hospital and do your interventions real-time in the ward, basically that means that you're actually doing from the patient level upwards, because this is the data that will actually relate to the CASIC and towards NASIC, and then from there probably go to the GLASS. So having this tool, our tool has all these modules. I think you can see them on my left. I'm assuming that's on your right. So it has an AMS chart review that you can use every day on your everyday ward rounds. You have an AMS knowledge hub. There is a section for microbiology data. You can do your reports, your AMS reports, that is, and then settings, which I don't really know much because I'm not really that much of an IT guy. So when you go to this and when you're looking at the tool, I'll allude to a few people who actually spoke in the morning, especially the partners who were here in the morning. Bolivar from Fleming Fund, I think Dr. Mbajo from Fleming Fund, Dr. Sigei from Biomeru, and the main thing that we were talking about was sustainability. Actually, we are thinking about this. Our partners come to the facility, and after that they go. So what next? And the challenge now, I think, goes to MOH in terms of trying to make sure that we actually have a level of sustainability in our facilities. So what can this tool do in terms of sustainability? So the WHO has a model for sustainability where it looks at the structural indicators, the process indicators, and then there is the outcome indicators. So structural indicators are things like leadership, commitment. You have your process indicators, which I'll show here in a minute. And then you have your outcome indicators. So once you have treated your patients, your outcome indicators are things like probably the length of stay in the hospital, how many patients come back for readmission. These are things that actually measure things like treatment failure. So your process indicators, you have things like compliance with current guidelines for surgical prophylaxis. I need to point out that through one of our partners, I think available, who is here, Find, we're actually able to do our own surgical prophylaxis guidelines. So that is something that we use as a measure. It's in blue, so that means that the tool can actually measure that as a process indicator. You can check for the indication of the antibiotic use, and I know very many facilities, especially the public facilities, like to write an arrow which just goes to your right that says CT therapy. So we need to indicate the duration of antibiotic use, or have they indicated is there an indication for the antibiotic use? Did they stop the surgical prophylaxis within 24 hours after surgery? You're thinking about things like IV to oral switch. Again, there are guidelines in regards to how you can actually transfer a patient from an IV to an oral. And what benefits do you have by doing this? You have benefits in regards to things like costs, whereby you can actually reduce the cost, the comfort of the patient. You're talking about your HAIs, you're talking about, there are a lot of things that you're looking at when you're talking about the IV to oral switch. So these are the kind of things that you can actually monitor by use of this tool, or some of the things that you can actually do, or you're supposed to do when you're doing your AMS ward round. So you need to, like, does your prescription or that your ward sheet have a stop or review date for the antibiotic? 48 hours review, and then I like this very much, de-escalation. If your patient is doing well, probably de-escalate to a more appropriate antibiotic. Now, a few challenges. This is what the tool can't do. It can't measure compliance with current clinical and treatment guidelines, but I believe that problem was sorted as of 1:12 p.m. today when we launched our antibiotic use guidelines for Kenya. So ideally, this is something that should actually now be a reference point for measuring the compliance with clinical guidelines. Surgical prophylaxis within 60 minutes, again, that is something you can't measure because it is written, but was it really done? So again, not really easy to confirm. And then the length of therapy by indication, but now with the guidelines, I think it's something that we have a reference point for. So benefits include things like improved rational use of antibiotics. I've talked about the cost savings, and then probably better compliance with AMS protocols. Most of what I've pointed out is for probably what I'd call the clinical interface, but then again, there is the microbiology interface. So it is actually very important because it ensures targeted therapy and reduces more of, probably I would call it empirical or antibiotic use. So the tool has integrated with the lab results. There's a real-time update on the culture and sensitivity findings, but again, this is something that we hit a snag on because of automation issues, and we have shifted to a new tool within the county. And then it can also do automated recommendations for therapy adjustments. And I like this synergy because I also saw another presentation at the back there which talks about probably use of AI for for extrapolating a decision for clinical results. So the WHO has two ways of looking at the benefits in terms of sustainability. One is qualitative, the other one is quantitative. So in terms of quantitative, we can look at things like decreased expenditure on antimicrobials. You can measure your DDD, that is your daily defined doses, which is a measure of antimicrobial use. You can check on things like length of hospital stay and also reduction in irrational use of antibiotics. In terms of qualitative, you're looking at things like improved antibiotic use. You can also monitor the trends in AMR. You can compare the antimicrobial use among wards. So probably you have a surgical female and male ward. So it's easy to actually compare the two because they tend to treat plus or minus the same morbidities. And then also improve patient care because you can actually do real-time patient intervention and actually document that, report that. Probably the idea is now to actually think about how we can actually scale this up from the facility level to a national level, so that if I'm in Makueni and we are treating the same patient with probably, let's say, prophylaxis for a cesarean section, why not replicate the same in Tharaka Nithi as an example? Then finally, these were the risks that were there. You have things like lack of ownership. So this was mitigated by leadership buy-in, lack of capacity to use the digital platform. This was mitigated by things like continuous training, and we incorporated the IT team. And then lastly, the lack of access to internet and computers. So the tool is more of web-based, but you can actually upload this when you are offline, and then when you go online, it can be incorporated. I need to point out that the IT team is actually part of our AMS team in Makueni. So in conclusion, digitalization is a key strategy to improve AMS. And then we anticipated benefits in cost, some of them which we have seen, and antibiotic use management in the facility. Lastly, I'd like to thank the following partners: FIND, React for technical assistance, FAO, and the county government of Makueni for this. Thank you. I know I exceeded by 1 minute, but shukran.
Okay, thank you so much, Dr. Gavin, for that presentation. I'll take us through the rest of the session. My name is Dr. Ringi. And for the next presentation, we'll have Dr. Anima Sirma who will take us through infection prevention and control in animal health as a key pillar in containment of foodborne AMR. Welcome, Dr. Sirma.
Thank you very much, Daniel and Winnie. I know she was pushing me to send this presentation after lunch, and Christine was asking me, how do you people manage last minute 844? I'm happy now we've changed the system, so hopefully they're better prepared. But anyway, I'm Annie Masirma. I'll be doing this presentation on behalf of my other colleagues, Dr. Alan Ezegele, who's the Director of Veterinary Services, Dr. Agnes Maina, and Dr. Evans Muduma, who was in the lounge session. So we're looking at IPC, that is infection prevention and control in animal health, as a key pillar in the containment of foodborne AMR. So what is AMR? I know that's what we've been talking on, and this being the AMR Awareness, World AMR Awareness Week, it's important that we keep reminding ourselves about this AMR, what it is, the ability of these microorganisms multiplying or persisting in the presence of increased levels of antimicrobial agents relative to susceptible counterparts of the same species. Very scientific, but in short, they are just not responsive to previously effective antimicrobial drugs. So definitely it poses a public health threat. I'm within the veterinary public health division within our directorate, so we apply veterinary knowledge to improve public health, and some of the things we look into, AMR is also part of the subjects that we are working on. So for agriculture, we use antimicrobials both for therapeutic and non-therapeutic purposes. If you want explanation on that, you can see me behind the tent. So how does it spread? I'm talking about the food, from food animals to humans. Mainly there's direct contact with livestock, and this is relevant for agricultural workers. Veterinarians are included here, who are constantly in contact with these animals. There is also now the other route where the resistant bacteria are passed from the food products, livestock-derived food products. We can have milk, meat, honey, even table eggs, get to us as humans, we consume. And then there's the other route whereby we have animal waste, manure. We commonly use manure as fertilizer in crop production, so that's another route that we can spread this MR, the resistant bacteria or other microbes to us, and then also they can contaminate water supplies, and you have this in the environment. So what are the implications of AMR in animal health and animal resources? So there's poor animal health and welfare. Definitely, if the animals are sick, they're not well, their welfare is not good. It increases cost of animal health care because you definitely, of course, the cost goes higher. And then financial losses to the businesses, if the farms, the higher mortality, decreased feed conversion, reduced production and growth, early culling and breeding of animals, dairy cows. This is not what you would want to see for a farmer. Of course, livelihoods lost, people are dependent, it's their businesses. If you're having 2 or 3 animals, mostly in the country, people are smallholder, you have very few animals, so if you lose your beloved cow or due to AMR, then it's a livelihood loss. Then high cost of animal source foods, that now comes to bite us, whereby now the milk that was produced, the cost of producing milk was this much, but because of AMR increased cost of healthcare, it rolls over to us. So on the right, that's that drawing. I think Dr. Romona touched on it in the morning, those worrying figures by 2050. This was a study funded by the UK government and Wellcome Trust. And the interesting bit is the prediction has shown the model mortality per 10,000 people due to AMR in Africa and Asia combined, that is by 2050, would be nearly twice that of mortality in North America, there's Europe, and there's Australia. So the burden is with us, us being in the African continent, so we need to really look at it and see what to do to mitigate it. So in terms of foodborne bacteria, or mainly I look at the bacteria, what are the ones who are zoonotic, the ones that can be transmitted between humans and animals. There's a Salmonella species, Campylobacter, E. coli, Staphylococcus aureus, MRSA is of importance to us. It's also been picked in livestock. Listeria monocytogenes, these are important foodborne pathogens, and it's important to highlight that in our surveillance, we have active surveillance protocols for dairy and poultry. The first three, we are looking at those bacteria, but my colleagues here can correct me if I'm wrong. Then IPC control of foodborne pathogens, the stages of food production from production that's at the farm level, mainly processing, distribution, preparation, consumption. So there are measures that can be put, infection prevention and control measures along this chain to curb the development, reduce the development and spread of AMR. So good agricultural practices, good animal husbandry practices, good manufacturing practices. For you pharmacists, you know of the WHO, GMPs for biological products, but we have GMPs for food, in food, and they revolve around the 5 Ps for GMPs. Look at the people, the processes, the procedures, the products, the premises, what can you do around that so that food is consistently produced and controlled according to a set quality standard. Sanitation, pasteurization procedures, HACCP, and all these are available online. FAO, WHO, they have documented. If you even you can customize, and I would encourage our CASICs in your work plans. These are some of the things that you can do and roll out to the farms, roll out to the key people who are in food production so that they can implement in their enterprises to assure that that we won't have spread of AMR bugs through food. So HACCP, if you read the abstract that I submitted, I mentioned this HACCP, hazard analysis and critical control point systems. I know it's a very scientific process, it's determined, but we take HACCP as a preventive approach to food safety, whereby even our mama mbogas, our people who are selling milk, we encourage them. I think in my future, I would plan to do, Ramona is laughing, Dr. Ramona. So, like the way you find in TV, you're recorded, you're given a word, and you say it. It's like a tongue twister. I'd go around to maybe the people selling sausages and all that and ask them, can you tell me what are your hazards, of course in their language, what are the hazards in them, whatever they are doing. Can they identify 2 or 3 hazards? How would they control it? Those are the control points that we want them to know. If they're able to know, if I go to the loo and I don't wash my hand and I come and sell and touch that mboga, that's already a problem. It's a route through which now I can spread bacteria or whatever, or the microbes. So there are quite a number of examples of HACCP-based controls that can be put in place. There's a cooking. At cooking preparation temperatures, you should know how long, cooling, refrigeration, hot holding. When we are going to serve here out for lunch, look out for those. Some of those foods should not be just left in the open. There should be a set temperature that is known, that is determined, that within this temperature we can control the growth of microbes and prevent people getting infected. Testing, you can use laboratory. Some even use just your testing by your tongue, you can tell. Calibration is important for the equipments that we use. Hand washing, that cannot be overemphasized. And training. Training is quite important. Then I look at, based on HACCP, I know HACCP is scientific, but we have incorporated these principles of HACCP in our laws. For example, I'm from the DVS. We are in charge of enforcing the Meat Control Act to assure safety of meat. So part of the laws, some of the requirements, if it's for the premises, the establishment, the slaughterhouses, they're embedded. Those are sub-principles. They're embedded there, and those are the things when we license, when we give approvals, registrations, those are the things, the key things we look at. And we'd like to encourage the people who are in the informal sector, sort of illegal in a way, to join the formal sector, because it's through that when we issue those approvals and licenses, we can check on them, we can check that they have implemented, but more important is we want a change. We know some of us, personally I'm a farmer in my own small or big way. You're a food business operator. If I'm in the process of producing food, even if it's my own consumption, because I can have guests, have I checked what are the key measures that I need to put in place to ensure that I produce safe food? It's not up to the government only to check on me so that I give food that is safe. Everybody has to take responsibility, and we say FBOs might take responsibility for safety. So they have quite a number of agencies. I know it's not clear, but we have, of course, the DVS, VMD, in terms of the now controlling the drugs. Actually, now you have KDB, dairy safety, PCPB, pesticides, because these are used even in feed production. They end up in the animal feeds, the residues in food products, although that's another subject, food safety subject. So KEFIS is there in terms of plant health, KEBS in terms of standards, although we all collaborate in making these standards. AFA, Agriculture Food Authority, Kenya Fisheries for aquaculture products, government chemists for the testing, CALRO is there for research, national public health labs. There are quite a number of Kenyan institutions involved in food control, and I'm happy to say that we have our own committee for coordinating matters food safety, where we regularly meet and regularly exchange on what we are doing, what measures we are putting in place, and WHO approved 7th June, World Food Safety Day, every year to be celebrated. We commemorate and look into the actions we are taking towards improved food safety in the country. So IPC coming back home, our National Action Plan, this is our issue number 4. Sorry, thanks, I've noted. And part of those are the ones that are relevant to food. We have 4.15, disseminate and implement farm biosecurity guidelines. I'm happy to say that we already have published the guidelines that are available for the counties. If you want, please get in touch with us to get them and see how you domesticate. Advocate for vaccination. I'm happy even in the current government, there's vaccination going on for animal that's already been launched. Strengthen hygiene and food safety measures in food value chains. That is what we're consistently doing, consistently revising the laws, the regulations, consistently sensitizing the stakeholders, especially the ones we call FBOs, food business operators. Strengthen GAPs. There we consistently come and what do you say, disseminate to them. Although they're available online, anyone can get. So thank you for your attention. We have our quacks there, KVB. So the animals are shouting, we need you to handle antimicrobials with care. Thank you very much.
Okay, thank you so much, Dr. Anima. And thank you also for keeping time. We're almost there, so just hold on a bit. So we now have our last presentation from Dr. Dennis Githinji. Dr. Dennis, are you around? Yeah, thank you. And Dr. Dennis will be presenting on perspectives on the regional strategy for implementation of national action plans on AMR in the WHO African region. Thank you. So, karibu, Daktari.
Hello, good evening. My name is Dennis Kedenji. I'm not yet a doctor. That's a correction. So I'm an independent consultant, and one of my clients is the WHO Regional Office for Africa. So I conducted this work in collaboration with the team in the AMR unit of the World Health Organization Regional Office for Africa. It's a project that is part of documentation of the transformation agenda by the World Health Organization, which is a project that has been ongoing since 2015. So I conducted this work independently, but I was paid to do it. That's my declaration of conflict of interests. So there was no influence in how the study was conducted by the office or anyone else. So this work stems from the realization that countries have progressed, we would say well, in the implementation of national action plans. But then the World Health Organization recognized that there is a need to fast track the implementation of the national action plans. So that's why it developed the regional strategy to facilitate the implementation of the national action plans. And this regional AMR strategy has various recommendations and also indicators for measuring progress. So it was launched in August 2023, and we did this work sometimes in November and between November and January, November 2023 to January 2024. We wanted to check the status of the various member states. We have 47 WHO member states in Africa, so we wanted to check how they have fared in implementation of the aspects captured in the regional strategy. So these were the focus areas. There's the strengthening of coordination and governance driven by the One Health approach. Then there's improvement in awareness and understanding of AMR, enhancement of knowledge and evidence generation on AMR rates and antimicrobial consumption. And then there's the optimization of the use of antimicrobials in humans. So the purpose, I've already indicated that. The objectives align with the 6 priority areas outlined in the regional strategy. The regional strategy is already published. You can check it online. So I won't go into that in depth. But then an overview is that, one, there is the aspect of multi-sectoral collaboration and coordination committees. Their establishments, they are functioning. There's also in-country monitoring and evaluation systems. Then sustainable investments on national action plans, awareness and education, initiatives to reduce the incidence of infections, and the optimization of the use of antimicrobials in the fight against AMRs. So what did we do? We conducted an online survey. Of course, we used a cross-sectional study design. This survey was directed to WHO AMR focal points. So we had at least 1 per country or 1 per member states. They were invited to complete the online survey, and the survey comprised open-ended and closed-ended questions. For the closed-ended questions, they were required to rate various statements regarding the implementation of these various aspects in the regional strategy. So, and then the closed-ended questions were about their recommendations on what their countries can do to further progress in the implementation of the initiatives. So For the ratings, we analyzed the data by getting an overall score for the various categories for the 6 target areas. So we had subscales for each of them. And then after getting the total score for the subscale, we divided it by the total possible rating. And then that percentage, we categorized it to give us a perception of how the implementation is. So we regarded 0 to 25% as inadequate implementation, 26 to 50% as basic implementation, 51 to 75% as intermediate implementation, then above 75% as advanced implementation. So then for the recommendations or the open-ended questions, the feedback we got, we analyzed it thematically to generate recommendations on the priority interventions that countries and the stakeholders that intend to support various countries can support. So 36 of the 47 member states responded to the survey between November 2023 and January 2024. We noted that there was intermediate implementation for 4 out of the 6 priority areas. That is the multi-sectoral coordination and collaboration committee, the establishment and satisfactory functioning, then raising awareness and education, building of knowledge and evidence base, and reducing infections that predispose to AMR. The areas that were least implemented are 1, the optimization of the use of antimicrobials, and then the promotion of sustainable investment for national action plans on AMR. So, since this symposium is about Kenya, I'll give a brief of the findings we got regarding Kenya. So as you can see in that map, Kenya is amongst the African member states, or the countries in Africa that are member states of the World Organization that have AMR committees. So the multi-sectoral collaboration and coordination committees, Kenya is amongst the countries with them, and actually the AMR focal points in Kenya rated it as functional, and they were satisfied with its functioning. So there's a general view of what we found in the region. So for figure 3A, you can see that we have communications and education and awareness campaigns, strategies in most countries. I mean in 15 out of the 36 countries. So that means 21 countries are yet to have the strategy for communication, education, and awareness. And then for B, out of the 15 countries that responded on that aspect of the implementation of the campaign strategy, remember there's having the strategy and there's the implementation. So only 13 out of the 15 and implemented. And so as you can see, I won't go into that in detail so that we go to the information on the Kenyan context. So there's an extension of that regarding the availability of active hospital-based antimicrobial stewardship programs and the integration of AWARE. I've heard some of you mention AWARE categorization, its integration in national essential medicines lists or treatment guidelines. So the red highlight shows you where there are inadequacies, or the number of countries that have, the proportion of countries with inadequacies. The manuscript is already published, so you can access the details online. So this figure illustrates how each aspect was rated. So you can also understand the details of this by accessing the manuscript online. Areas that require prioritization, that is in the Kenyan context. One is the supporting of multi-sectoral One Health collaboration activities with financial and human resources, not financial and human resources. Then integration of the antimicrobial use and emergence of AMR in curriculum of secondary and tertiary learning institutions, not secondary learning institutions, because I think that's where inadequacies are. Then the application or the use of incidence and prevalence information to monitor effectiveness of interventions in the country. So we generate that data in our universities, as some of you have indicated, but do we use it to inform our monitoring activities? Then we need to strengthen healthcare facilities to conduct surveillance of hospital-acquired infections. And then we need to incorporate surveillance for AMR pathogens in communities and environments. Beyond the hospital, we also need to enhance surveillance for AMR pathogens. Then we need increased investment in research and development to address AMR. Lastly, we need to dedicate a budget line for AMR. Those were the recommendations for Kenya based on the perspectives of the AMR national focal point in Kenya. Thank you for your time.
Thank you so much, Dennis, for that. So we'll have a quick Q&A session, a very quick one, just 2 questions per max. So per presenter, so I'd like to call upon all presenters. You can just come here to the plenary. So the presenters we had for the afternoon. And I hope you've been noting your questions. So we'll just rotate the mic around so that if you have a question, you can just ask. I'll just encourage our presenters to note down the questions, then we'll address them all together because of time. Thank you. And please bear with us. We know we are a bit late, but won't take much long. Thank you.
Okay, thank you so much, and I'm privileged to ask the first questions. And I have almost one question for each of the presenters. To the first presenter, I really appreciate the role of academic institutions on AMR. And when I listened to you very well, Dr. Risara, you are focused on research, which I want to find out whether many other universities are doing the same. That your research is mainly based on antimicrobials within the hospital setups. Are there any research that has been done to, for example, try to find out what happens within our environment? Because I want to believe most of these antimicrobials, we acquire them in the environment. And I just want to give one example. Most of these microorganisms that we get them through what we take in or what we eat. And I would be interested to know whether universities within their strategy are also keen to try and establish what is really happening in our environment. And for example, water that we consume. Do we have any research to that effect? Number 2, to the veterinary, I think this is for Sarah. Not Sarah, rather. She was talking about IPC in veterinary services. I want to find out whether there is any tracking of the 12 listed microorganisms by WHO, that you have identified those microorganisms that affect the veterinary services, that you have strategically put in place to follow those specific microorganisms listed there. Then for Kilifi, the last...
Let's restrict to 2, then others can ask. Then we'll come back if we have time. Sorry.
Okay, thank you so much.
Yeah, thanks. I'll allow Sarah to just respond. Then we'll have Sirma before we pick another set of questions.
Thank you so much for that question. He wanted to, if I may paraphrase, to know much about the research in other universities. Maybe as a representative of the university fraternity, I can say yes, much is going on in terms of research as concerns the environment. Much of the work that is done by the university staff or students or any work, any research work is usually published, and you can get it online. There's a lot on wastewater research, the environment, and there has been so much research on correlations on those microbes or organisms that are resistant to antibiotics, correlations between the environment and the human bacteria that is found in human body. Others will include not only the wastewater, but even basically in the environments where we are living, even in habitats like the slaughterhouses and all that. There's much which has been done, and it is published. Thank you.
Thank you, Sarah. We can proceed to Sirma.
Thank you very much for the question. And I think for the university, just as part of my presentation and linked to his question, I'd also like to pass on that burden that let's look at, the various routes of the human exposure. There's a livestock-derived route, and there are other routes. How significant is it in terms of contributing to AMR to humans? Just food for thought. So on the priority bacteria, the WHO list of priority pathogens and surveillance had reported that we are also tracking Salmonella species, E. coli, Staph aureus as part of our active surveillance under Fleming Fund. But we also have our own passive surveillance that we routinely, whenever we receive samples of milk or other samples, we test for resistance and report the AST findings. Thank you. But Dr. Romona is here if you want to add on that. He was asking about amongst the foodborne pathogens, the bacteria that were listed, how many are we tracking? And I was saying in our active surveillance protocols, we are tracking Salmonella, E. coli, Staph aureus, but we also have routine passive surveillance that we undertake. Thank you.
Yeah, I think that's correct. To add on to what Sirma has said, in our surveillance strategy, currently our surveillance strategy is a One Health surveillance strategy, meaning it encompasses all the 4 sectors, and it outlines exactly what we need to do to pick out issues of AMR. So for the pathogens, the priority pathogens that we have selected, that we are looking at in our surveillance strategy, are based on the WHO pathogens. So we may not look at all of them because some of them are human-specific, like Neisseria, gonorrhea, that's human-specific. But all the rest that we can also find them, say, in the environment, or we can find them in the animal populations, we actually look at them. But then we have prioritized. So currently it is E. coli, it is Salmonella, It is Staphylococcus aureus and
Enterococcus.
Sorry?
Enterococcus.
Then Enterococcus and Campylobacter, even though currently they are not in the WHO priority, they were in the previous list of priority from WHO. Thank you.
Thank you so much. Do you have any questions for the other presenters?
Any other question for our other presenters?
Thank you very much. Good presentations. My question goes to, is it Helen from Nanyuki? Edna, sorry, Dr. Edna from Nanyuki. I saw in your presentation you talked about use of WHO aware categorization, and I wondered why you did not reference the local documents. We have a KML by aware categories, national formulary by the same, and I know there's a difference in terms of the categorization. Thanks.
Thank you. Any other question? Guys at the back. Hakuna swali.
Any question? We at the back. Okay, one more.
Thank you for the presentations. I think mine is to Warda. I just needed clarification. When you said that there was improvement in, the staff or, the CAP respondents in that AMR cannot be prevented, or they understood that, how do I put it? I'm not sure. My question being, did you make it clear that AMR is actually a natural phenomenon and does happen naturally, but it is up to us to actually slow it down? It seemed like you meant they understood that we can completely eliminate AMR. I think that's what I'm coming to. Thank you.
Okay, thank you, Dr. Tracy. So, okay.
Hello, good evening. Mine is to Dr. Gavin Orangi. Whatever tool they've put up as a county, I believe is a co-creation. So my question to him is, because he said he's looking at the possibility of dissemination, or rather escalating to other counties. So will other counties start creating their own digital tool for MS to replicate what you've done, or you intend to scale up the very same tool you've built to other counties? Thank you.
Thank you. We can have the presenters respond to those questions. We'll start with Edna.
Mine was actually more of a comment and also a proposal. And yes, I agree. We went with WHO because it's universal, but it's key, as Dr. is saying. We come home to the Kenya Medical Essential List, which I wasn't quite, we didn't keenly look at that, but I think next time that's what we're going to go to because it's home in Kenya. Thank you.
Thank you.
Yeah, thank you for that question. I think the question was assessing about, do we as healthcare workers, do we have a role in prevention of AMR? Yes, AMR can happen like when mutation happen, and again, now the main causes of AMR is the misuse of the antibiotics. So we were trying to find out, do we have a role like us healthcare workers in contributing to the prevention, not rather eradicating? Like when you use our antibiotic properly, when you practice good hygiene. So there was a 3% who thought like MR is just something which just happened, right? But rather we can contribute it to it. And that's what we were assessing, like prescribing the practicing good prescribing, like avoiding these antibiotics when they're not necessary. So after that, when we had several CMEs regarding what the phenomenon of AMR, how it happens, and how we can prevent, I think everyone agreed like we do play a role in the prevention of this threat.
So in regards to the dissemination of the tool to the other counties, when the partners came on the ground to Makueni County, the first thing that we did, we sent an MOU or a memorandum of understanding between the county government and the various partners. In this case, we had React Africa, and then we also had Find. When we were developing this tool, part of the MOU, what we stipulated was 100% of the data, and this was also covered by the Data Protection Act, 100% of the data was supposed to be owned by the county government. However, the tool having come from our partners, and our partners came from NASIC, that is the MOH. The MOH was also a co-partner in the co-development of this. So through NASIC, it's something that probably can be, it's an idea that was mooted that probably can be spread out to the other counties or to the other facilities that are out there in terms of dissemination. Thank you.
Okay, thank you so much to our presenters for that amazing session. So I think we've come to the end of the session, but as we go out, we can just pass by the posters and see the wonderful research that is also happening that maybe was not presented. So thanks so much, our presenters. We really do appreciate and your commitment and also sharing your work with us. Thanks so much, everyone who attended today. It was a pleasure having you all with us, and we appreciate the dedication. And so I'll hand it over to my co-moderator. Thank you.
Before you clap, simple instructions. Emmanuel, umechoka. Anyway, the veterinary paraprofessionals can visit the lady at the back. Please raise your hand. Watu wakuone, yeah. So you can sign the attendance for your CPD points. So thank you very much. I want to close today's session. And
before we close, I hope we've all registered, especially also for the pharmacists around. So you're also trying to get some CPDs. So please register through there was a Google form that was shared, you know? Yeah, so kindly also register for the same. Thank you.
so asante sana. I think we've had a long day. Some of us have had a long night, long day. Okay? Yeah, so we want to thank all the presenters who showcased what they have done in terms of implementation science. And we'd like to close today's session. And tomorrow we start at exactly 8. If we are here at 8:30, it's going to be a long session because we have a lot of presenters who will be showcasing their work tomorrow. So I want to close there. Okay, let me call our chair.
No, let's give a round of applause to the moderators. Nice ones. We need some energy. They have done a good job, and I'm sure all of us have learned a lot, and we are going to continue this conversation beyond this room. Please go tell someone. I have an assignment for everyone today. I'm a teacher, so we love assignments. Please go tell someone, just at least one person, about what is AMR, how does it develop, and how do we all contributing towards AMR, and how can we, through our behavioral change, do practices that reduce the spread of AMR. Meskia. Kesho mkiingia pale, that will be the first question. How many people have you told about AMR? Because this week is about awareness creation, right? So let's do it more and more so that we create a critical mass of people who do the right thing so that we mitigate the AMR in our country, reduce the AMR in our country. So that said, we have tea outside. Please don't leave the tea. Make sure you take some tea. It will calm you down to make you feel better. And then tomorrow, please make sure you come early so that we continue the conversation. Thank you very much and have a good evening.
I've
I've just been reminded we have not prayed. Sorry. We opened with a word of prayer. Let someone pray for us, please. Anyone, any volunteer. I would pray all the time, but since I'm the chair, I can't. Yes, please. Thank you.
So let us pray. Father, in the name of Jesus, I want to thank you because of this time. Lord, we had asked you in the morning that you be together with us. We thank you, Father, because of what we have been able to do. And Lord, even as we part, we pray that you shall be together with us. And even you shall protect us. And even as we come here tomorrow, we shall be able to continue, Lord, with what we are supposed to do with this particular event. We give you praise and worship your name. For it is in the name of Jesus we pray and believe. Amen. Thank you.
Yes, this tea. Msiwache chai, nimekumbushwa. Poa. Si niko na gari.